Dan, got that prescription pad handy?
Yes.
I get the feeling we may need that by the end of this conversation, but let's see how we go. Thank you so much for making the time to join us. You're out here in LA for a conference.
Yes, that's right, Simon. It's my pleasure. It really is my pleasure to sit with you and talk to you. I listen to your podcast, so I've been looking forward to meeting with you.
I think it was Carol Kirkpatrick and Kevin Mackey who were on the show a few weeks ago that introduced us, or maybe it was Thomas Dayspring. I couldn't recall.
I think it might have been Tom.
It was Tom.
Yeah.
Okay, so thank you, Tom, for that. I was really interested in a recent clinical consensus paper that you wrote on ApoB with Carol. Was Carol on that paper too?
Carol and Kevin.
Yeah. There we go. So the three of you and a team from the NLA, National Lipid Association, wrote this really informative paper on the role of ApoB in the management of cardiovascular disease risk. And ApoB has been something that we've covered on this show, of course, with Tom in a lot of detail and in other episodes, but we've never had a kind of dedicated episode that is sort of aimed at helping the individual who's listening, who's just thinking, how do I assess and reduce my risk of cardiovascular disease? And then also there's a lot of clinicians that listen to this show as well. And so I think it will be helpful to kind of unpack the consensus paper and informative for both of those different types of listeners. You mentioned to me on a call that you come at sort of preventive cardiology, lipids, atherosclerosis, not so much from a research point of view, but more so from a clinical point of view. What does that kind of entail or look like for you on a day-to-day basis?
Well, thank you for mentioning that Carol and Kevin were both on that paper. It was actually, I just want to say it was really a team effort. And I had the pleasure to co-chair that with Alan Romali, who is a real ApoB and lipid scientist at the NIH. And then the rest of the team, I'm not going to go through all the names. It's too many.
We'll put the link in the show notes.
Yeah, make sure that they all get credit. And I also want to make sure, we had some credit given to people who were not authors on that paper, notably Alan Snyderman, who has taught the world about the importance of ApoB. And we wanted to make sure that as the first official statement that the National Lipid Association has created, that I personally wanted to make sure that Alan Snyderman got the credit that was due relating to the impact of ApoB. It's not that this is the only statement that will ever be written. I just wanted to make sure that was acknowledged in this paper. And with respect to my perspective, that's right. It's a stretch to call me a scientist. I am a clinician. I was trained as a clinician. I went to medical school because I knew I wanted to take care of people. I even before that, when I was in college, I didn't know what I wanted to do, but I knew I wanted to be impactful to people. And I found my way to medicine. And then within medicine, the only model I had personally was, being a clinician. I didn't know that you could be a doctor and do anything but be a clinician. So I went into it with not exactly open-minded, but literally just I knew the world that I knew, and every doctor I knew was a clinician. And it wasn't until I got there that I started to realize, there's people coming to medicine from all different approaches. We had PhD scientists, we had people who had previously been nurses, people who wanted to run governing bodies, people who wanted to just do education. And I was learning from scratch really at that point. And I've spent my entire career as a clinician. I've been in practice for 27 years. I initially in primary care internal medicine, and I gained an interest in clinical lipidology after I'd been in practice for a few years. And I've been practicing in both primary care and clinical lipidology for the last 17 years. And just in the last 3 months, actually transitioned to solely a lipidology, preventive cardiology practice. So even though the rest of the country and the world is in a panic because of a shortage of primary care clinicians, I made things a little bit worse by giving up my primary care internal medicine. I apologize to the world for that, but it was the right time and the right thing for me to do at this time in my career.
Well, we're certainly grateful to have you focusing on lipids and lipidology, and I'm sure there's a lot of patients out there that have been under your care or are under your care that are really grateful as well. For people that are kind of hearing of clinical lipidology and lipidologist, lipid specialist for the first time, and I'm asking this question for myself too, how does that differ in terms of management and how the types of patients you're seeing or how you're treating patients, managing them compared to a cardiologist?
The training is different. So one of my duties is to train the cardiology fellows at the University of Pennsylvania on lipid practice and make that part of their curriculum. And so we have clinical opportunities to train them, and we have didactics for them, and some individuals actually do extra. But most people complete their cardiology fellowship training without much dedicated lipid specialization and without much dedicated time spent in lipid clinic, because lipid clinics don't exist at every institution where there's a cardiology fellowship training program. So cardiologists are expected to have a fundamental understanding of lipids, or at least in the management of most care. And it is possible to understand what to do without understanding the why to do it. And you can probably still help people a great deal. I think the difference between someone who has dedicated time to becoming a lipid specialist is that you understand at a deeper level, because you spend your time thinking about not just lipids, but the lipoproteins that carry the lipids, the integration of the various metabolic consequences or triggers that cause derangements in lipids and lipoproteins, the syndromes that occur as a consequence of inherited and environmental factors, and other consequences that go beyond heart issues. So cardiologists, may not focus on, for example, the ramifications of chylomicronemia that causes acute pancreatitis. That's not really their bailiwick. On the other hand, some other specialties get involved too. So endocrinologist is another subspecialty of internal medicine that tends to have a high level of expertise in lipidology, and a lot of lipidologists come from endocrinology, but not all endocrinologists have expertise in lipidology and lipoprotein science either. My interest came from primary care. And even though I was undifferentiated when I finished my training program, within 5 years of being in practice and doing additional education on my own, it became clear that if I didn't have a high level understanding of cardiometabolic diseases, especially lipid and lipoprotein physiology, then I was doing my patients in primary care a disservice, because chances are I was going to be the one that they were going to see and rely upon to make decisions about cardiovascular health, atherosclerosis, and other complications associated with lipid and lipoprotein abnormalities.
And just to be clear, when you say lipids, for the person who is not a doctor but has had a blood test, you're talking about LDL, low-density lipoprotein, that you see a result for LDL cholesterol on a blood test. You see a result for HDL cholesterol. You see total cholesterol. You see triglycerides. That's the part of the blood test that where it's saying is kind of falling underneath your specialty.
Exactly. So it goes beyond that, of course, but the standard lipid profile is where we start. And one of the things that is part of my training is that when I see a lipid profile, I go through the lipid gymnastics in my brain to understand what's happening at the lipoprotein level. Because the diseases that we manage that are a consequence of lipid and lipoprotein abnormalities occur because of the relationship between the lipoprotein and the organs that are involved, less so from the lipid. But it's a mouthful to tell people that I'm a lipoproteinologist. And so it's easier to refer to myself as a lipidologist.
Right. And of those diseases that could be attributed to these lipids, or more specifically lipoproteins. Is atherosclerosis, is that top of the list in terms of prevalence, incidence, and kind of burden of disease?
Yeah, absolutely. So the most important consequence related to lipid and lipoprotein abnormalities is atherosclerotic cardiovascular disease and all of the different ways that that can manifest. But there are other organs involved. Like I mentioned, the pancreas, pancreatitis is a consequence of hypertriglyceridemia when there's chylomicrons in excess, typically. There can be some skin manifestations, some kidney manifestations, but primarily when we talk about the consequences of lipid and lipoprotein disorders, the first and foremost, it's always about atherosclerosis.
Okay, so coming back to this new consensus paper, why the motivation to kind of dedicate a paper to the role of ApoB?
Well, it's really mostly related to the relationship to atherosclerotic cardiovascular disease and interpreting what we see on a lipid profile. I don't want to, harp on this too much, but really understanding what's happening at the lipoprotein level is really critical to understanding what's happening in atherosclerosis. And when you get a standard lipid panel completed, you really can't understand simply from the lipid panel exactly what's going on. You can't classify the condition as clearly unless you have additional information. So you can get that additional information by a lot of different techniques. Like you can do specialized testing, using fancy technology like NMR technology or other similar modalities to get lipoprotein testing. That's not available everywhere. There's some limitations in terms of validation at other centers and different techniques involved, and there's no standardization. So in our clinic, that's not something that we favor, but you can make extrapolations once you know things like the ApoB level in the context of the lipid profile. You can understand the lipoprotein abnormality better. And again, Alan Snyderman helped us with a tool to help decode the lipid profile using ApoB years ago when he and his team put together something called the ApoB app, which is an algorithm to help decode which lipoprotein abnormality is found. Alternatively, you can do it the old-fashioned way, from the 1960s and 70s, which we used to do at our institution up until 10 or 15 years ago, where you use a technique called ultracentrifugation to really separate out the lipoproteins. And then you can use another technique called beta quantification. So you can actually measure the lipoproteins directly. And because of this process, you can then really have them, which is considered the gold standard for understanding which lipoprotein is abnormal. But it's a work-intensive, time-intensive, low-throughput technique for getting those test results. That's why things like NMR and ion mobility testing are promising as an easier, faster, more reliable technique that doesn't require like a full staff. And at our institution, like many institutions, when the apparatus became less available, we started to have difficulty because it was an old apparatus. It just didn't make sense to continue. So using the gold standard ultracentrifugation test just isn't done anymore. So Alan Snyderman and his group actually created an algorithm from a database of blanking on how many people were in the database, where they had the gold standard test and the lipoprotein phenotype and the clinical presentation. And they were able to create an algorithm using total cholesterol, triglyceride level, and ApoB. And you can sort out which lipoprotein abnormality you have, which is, again, maybe we're too deep into lipidology. Like that is something that primarily a lipid specialist would be interested in, but maybe not the person on the street who's there just to find out, like, what are my risks for heart disease? But
I think the point for the person on the street, or even the doctor that's listening, is what is the added value of ordering something like ApoB as opposed to just looking at someone's LDL cholesterol, which is the more historically kind of popular risk factor that someone would look at to determine someone's risk of developing atherosclerosis.
Yeah, I think the biggest value is understanding something called residual risk. So you're familiar with that term, I'm sure. So what it means is that we know that atherosclerosis is a complicated process, that it's not simply based solely on how much LDL cholesterol someone has in their circulation. But we do know that if you lower the LDL cholesterol in individuals with atherosclerosis, that you will reduce their risk. You will reduce their chance of having a major cardiovascular event, less likely to have a heart attack, less likely to have a stroke. And we have clinical trial evidence that shows that they're less likely to die from cardiovascular disease. So that's important. But less likely is not going to happen. Right? That's not the same as telling someone, oh, don't worry, it's not going to happen. So there's still people on therapy for LDL cholesterol lowering who still have cardiovascular events. And the question is why? Well, it's again, atherosclerosis is complicated. Insulin resistance plays a role, hypertension plays a role, the smoking plays a role, genetic factors play a role. But there are other lipid and lipoprotein factors beyond LDL cholesterol that play a role. LDL cholesterol is fraught. I think I heard you on a different podcast talking about that I think with Tom, that LDL cholesterol, as you know, is generally not a measured entity. It's a calculated entity. And up until the last decade or so, and less really, and at my institution in the last year, we were using an antiquated technique for calculating LDL cholesterol that can be pretty divergent with the gold standard ultracentrifugation test. So we weren't even basing our decision-making on the right metric. On the right method of measuring LDL cholesterol. We were using an antiquated method for measuring LDL cholesterol and estimating. And so the good news is our colleagues have come up with better ways to estimate LDL cholesterol. You may have heard that of two such methods at Johns Hopkins. Seth Martin and his colleagues created the Martin-Hopkins calculator estimator tool. And at the NIH, Alan Romali and Murray Sampson created the Sampson NIH methodology. They're just different ways to estimate LDL cholesterol based upon the variables that we actually measure. And those two tools do a much better job at estimating LDL cholesterol. Even when you do that, though, now you have a better tool for estimating LDL cholesterol that, frankly, is superior to directly measuring LDL cholesterol, and you can still have residual cardiovascular risk when you lower LDL cholesterol using even better methods, and that can be because of other lipid and lipoprotein factors. You could still have high triglycerides, you can have high LPA. And you can still have a high level of ApoB even after you've lowered LDL cholesterol.
I think we need to double click on that just to remind people. So let's presume that someone is yet to kind of understand the difference between ApoB and LDL cholesterol. Let's walk through that story of what atherogenic lipoproteins are and how LDL cholesterol fits into that story and how ApoB fits into that story.
Sure. It might be worth taking a step back and thinking about what lipoproteins are in general and where they come from. Is that okay?
Yeah.
Okay.
Let's get foundational.
All right. So there's
because we kind of went 100 foot deep there.
Yeah. There's so the lipids that we are interested in the clinic as they relate to atherosclerosis are cholesterol and triglycerides. I don't do any metrics for phospholipids or other types of lipids. So it's really triglycerides and cholesterol. They are very important for different reasons. Cholesterol is a structural backbone for, hormonal synthesis and vitamin D synthesis and bile salt synthesis. It's a plasma membrane stabilizer. I liken it to rebar in cement. It fits into phospholipids and it has a rigid structure, so it gives some stability to plasma membranes and organelle membranes. So that's its purpose. And every cell in the body can make its own cholesterol. Certain cells are able to degrade cholesterol. And if you get too high of level of cholesterol in your cell, it has some toxicity. Triglycerides do something completely different. They are primarily a carrier for fatty acids, and fatty acids have a role in energy utilization, and they need to be transported throughout the body because certain parts of the body will have an accumulation of fatty acids and you want to transport it somewhere else for either storage or for energy utilization. And so cholesterol and triglycerides tend to run together, not because they share any structural properties or functional properties, but because they share this biochemical characteristic that they are nonpolar, which means that they don't have like an electrical charge, which also means that if you want to move them from one place in the body to another through the bloodstream, they don't dissolve in blood. So you need something to carry them in the blood. And that's what lipoproteins are. So the purpose of lipoproteins is to carry lipids or other nonpolar substances, including fat-soluble vitamins and things like that, through the bloodstream from one place to another. There's different lineages of lipoproteins. So, and there are different structural proteins that are permanent scaffolds for lipoproteins. So starting with HDL, because it's distinct from the other lipoproteins, HDL particles, their main structural protein is apolipoprotein capital A1, okay? To distinguish it from apolipoprotein lowercase a. So apolipoprotein capital A1 is the main structural protein found on HDL particles. And you can have one ApoA1 or you can have multiple ApoA1s. And you can also have apolipoprotein A2. So you have multiple structural proteins that can be found on HDL particles, but it's always in that ApoA capital A lineage. The origin of HDL particles is primarily hepatic from the liver, but also from enterocytes and also budding off of other lipoproteins. So HDL particles functionally are very different from the other type of lipoproteins in the circulation. And if we're going to talk about atherosclerosis, maybe we can talk about that as well. So the other lineages are all ApoB associated lipoproteins. And there's two main lineages within the ApoB world. So there's the enterocyte derived and there's the hepatocyte derived. So ApoB containing lipoproteins can come from the gut or they can come from the liver. The ApoB is the main structural protein for all of those lipoproteins. ApoB is the ApoB is different whether it comes from the gut versus the liver, but they come from the same gene. It's the gene expression is different depending on where they come from. But the gene gets spliced differently in production in the gut compared to the liver. The entire gene gets expressed in the liver, but only about half of the gene gets expressed in the gut. And so the ApoB that's found on gut-derived lipoproteins is called ApoB48, whereas the ApoB found from the liver is ApoB100.
Hence, so 48 being approximately half of the weight.
Exactly, yeah.
Gotcha.
And the part that gets cut off is the LDL receptor binding domain. So it's important because ApoB is the main structural protein on these lipoproteins, but it's also the principal ligand in its full ApoB100 form for the LDL receptor, the principal mechanism for clearing LDL particles from the circulation.
Meaning that protein, apolipoprotein B, that's on VLDLs, IDLs, and LDLs,
yes,
and including Lp(a) or and Lp(a), that protein is kind of what docks or like butts up and allows the liver to internalize that lipoprotein.
It's the key to the lock in the liver. Yeah.
Okay.
And so ApoB48 that's found on chylomicron and chylomicron remnants doesn't have the docking site. So in order to clear chylomicron remnants, it's not cleared through the LDL receptor. It has to be cleared through different type of receptors. And the liver expresses multiple ApoB receptors. But the predominant receptor made by the liver are the LDL receptors.
And so when you measure ApoB, there's one ApoB on each of these lipoproteins, right?
Yeah. So ApoB, the protein, is huge. It's over 4,500 amino acid sequences, and it's a very large protein. As a matter of fact, Alan Romali, I think I'm allowed to say this, is unveiling a new model that comes from I'm going to mess up the details, but I think it comes from electron micrograph studies actually showing very structurally intricate description of ApoB, and he's unveiling it at the American Heart Association meeting in 2 weeks. So I've had an insider's peek at this. It's very exciting for guys like me to actually see this in pictorial form, and it's the most accurate representation of what ApoB 100 looks like. So it's a big protein, and each lipoprotein can really only accommodate a single ApoB. So that's why there's a relationship of a 1-to-1. So for every one of those lipoproteins that we mentioned, they each have one ApoB. Whereas with the HDL particles, you can have up to 1 to 4 different versions of ApoA1. So you don't get a 1-to-1 relationship with their main structural protein.
What is it about ApoB, that protein, that differentiates, say, HDL from LDL with regards to why one is atherogenic and one is not? So my understanding is HDL, which doesn't have an ApoB, it has an ApoA1, so a different protein, is not at what we would call atherogenic. Maybe you can define that. Whereas VLDL, IDL, LDL, and LP(a), they all have one of these ApoBs on them, which makes them atherogenic. Can you kind of help us understand the distinction there?
So HDL's super complicated, Simon. The HDL is a lipoprotein that can vary in its lipid content in a lot, in terms of the amount of lipid that it carries. It has this great capacity for expanding and contracting and transferring lipids back and forth between other cells and other lipoproteins. So that's pretty interesting. You tend to not get quite as much transfer of lipid with, actually, I don't want to say it that way. It has a tremendous capacity to transfer lipid. It also has this incredible cargo of proteins with a wide variety of functions. So the proteins that associate with HDL particles have and that's been described as having at least 200 different proteins that associate with HDL, which gives it a great opportunity for a variety of functionality. Many of the proteins simply interact with other lipoproteins and enable lipoprotein changes and interaction with other lipoproteins. But they also carry proteins that have turn-off proteinases that are responsible for breaking down the structures of other proteins. They activate complement, which is part of the body's immune system. And so you get this wide variety of protein functions from HDL that really suggest that this is the ancestral lipoprotein that had function that went far beyond transfer of lipid for nutritional purposes, that it has an important role in the way our immune system works. And so the functionality is complicated and I don't think is very well described right now, but it's described fairly well. HDL particles can penetrate into the intima from the bloodstream, the space below the lining that's of the arteries where atherosclerosis develops. But it doesn't get stuck in. It can get in and it can get out. And that's an important function, activity of HDL that differs greatly from the ApoB containing lipoproteins. The ApoB containing lipoproteins vary in their size and they vary in their protein carriage as well. But the proteins that aggregate with ApoB containing lipoproteins tend to be proteins that strictly aggregate with lipoproteins. And those are called apolipoproteins. So an example would be apolipoprotein C1, ApoC2, ApoC3, ApoE. All of those apolipoproteins can move from one particle to another, and they can be transferred back and forth. Whereas ApoB is permanently part of the structure of that one particular lipoprotein, and you don't get it. So it's a permanent part of the structure. This size of the particles can vary greatly depending on the interactions of the ApoB particles with other lipoproteins and with cells, but they can only penetrate the endothelium to get into the intima if they're below a certain size. I'm not sure exactly what that size is, but I think most of the scientists tell us that it's around 70 nanometers. So once you get below 70 nanometers, the particles can penetrate into the endothelium. And I'm not sure what it is about being greater than 70 nanometers that prevents those particles from penetrating. But a nascent VLDL that just got released from the liver is bigger than 70 nanometers. So a nascent VLDL is not directly atherogenic, and it's not until it starts dumping some of its lipid and contracting to a smaller size that a VLDL remnant particle is small enough to even penetrate. Chylomicrons, which are exponentially larger than VLDL,
they're way too big.
They're way too big. So they're on the order of 1,000 nanometers when they first come out, and those particles may have a role in atherosclerosis indirectly. But in general, chylomicrons are certainly not directly atherogenic. They can't penetrate into the intima. All of the particles, all of the other ApoB 100 containing lipoproteins, like VLDL remnants, specifically IDL, LDL particles of all sizes, and lipoprotein a of all of its sizes, are smaller than 70 nanometers and have the potential to be directly atherogenic. So when they penetrate the endothelium, which is a complicated process, by the way, it's not simply just they went from the blood to the intima. They actually, there's a whole process for how they get transferred.
Is that normal? Like, would that happen under normal physiology, or is that only happening if the endothelial sort of cell lining is dysfunctional or damaged?
Yeah. I think both is true. So the concept, the model for how atherogenesis occurs has changed over the last 100 plus years, thankfully. So the original, the first real scientific model of atherogenesis was described probably best in the early 1900s by Nikolai Anichkov, and which the European Society of Cardiology and others, I think it's ESC, that honors a scientist every year with the Anichkov Prize.
Okay,
right.
Was he studying rabbits or?
Yes. So he's the white rabbit guy who overfed these vegan animals saturated fat and high cholesterol diet, and established that you can generate atherosclerosis with a dietary change in the serum level of cholesterol. And that formed the basis for the so-called cholesterol hypothesis. In the latter half of the 20th century, though, the Ross and Glomset were sort of originators of the concept of this thing called the response to injury hypothesis of atherosclerosis, which gets at what you were just saying is, wait, don't you need an injured endothelium to enable the movement of lipoproteins into the circulation? And that seemed a lot more attractive, because what if we have just like normally functioning endothelium and it acts like a nice Teflon coating, and shouldn't you need some sort of injury for that process to take place? It kind of matches what we know about cardiovascular disease, that hypertension and smoking and insulin resistance and inherited factors probably lead to this process as much as having too many LDL particles in the circulation.
And it gets to an important question, because then you're able to start to tease apart, are the lipoproteins inherently a problem, or are they only a problem in a certain context or environment?
So we know, for example, that atherosclerosis in the coronary vasculature and throughout the body tends to occur more commonly at branch points in the arterial tree, suggesting that there is some sort of endothelial damage that takes place as a result of the eddy currents that form at these branch points, right? So when an artery is perfectly straight, you get nice gentle laminar flow. But as soon as you introduce a bend in the artery, then you get eddy currents and some hydrostatic pressure influences that can injure and stress at the endothelium and enable sort of a nidus for atheroma formation. So we know that to be the case. I'm not a cardiologist and I'm not an interventionalist, but that's where atherosclerosis tends to form at these branch points. So that's one example of where we know an injury takes place. The model of atherogenesis, though, has evolved a bit since the response to injury hypothesis. And Kevin John Williams and Ira Taubes really, I think, deserve the most credit for describing this in the late 1990s as the response to retention hypothesis. So it sort of takes it one step further by saying, yeah, you need an interaction with the endothelium, but the endothelium doesn't necessarily have to be injured. That there are mechanisms that lipoproteins can penetrate from the lumen of the artery into the intima, and it's complicated how they get there. But one of the driving forces that pushes lipoproteins into the intima is going to be the concentration gradient of those particles in the circulation compared to the intima. So, and this is why knowing how many particles you have is more influential than just knowing about the lipid content of those particles. At least this is how I conceptualize it. So if you have a few LDL particles in the circulation that are cholesterol enriched, loaded with cholesterol, you can have a high level of LDL cholesterol, but the number of particles may be few.
Right. So it's just like you've got these very big beach balls floating around in there. Each of them is carrying a lot of cholesterol, but you don't have a lot of them.
And they're still way smaller than 70 nanometers. Right. They can penetrate the endothelium, but there aren't as many. So the concentration gradient is less compared to another individual who's got very small LDL particles that are cholesterol depleted, but who has a lot more of them. The concentration gradient is determined not by the cholesterol content of those particles, but by the number of those particles.
Right. So you can have a cholesterol level of, let's say, 120. Yeah. And you could have two people in front of you. One of them has fewer total low-density lipoprotein particles that are carrying more cholesterol than the other person who has smaller low-density lipoprotein particles each, but requires more of them to carry the same total cholesterol.
Yeah, exactly.
It gets difficult to explain, right?
Yeah, it can be difficult to explain, but I think most people get it. I mean, I don't like to create analogies because then people start thinking about the analogy. But there's a lot of different analogies that people have used. I've heard the beach ball analogy before, but that's the beach ball analogy I don't love because people then start to think, oh, it just bounces off the endothelium. I don't think that's what's happening. I think the more times that ApoB containing lipoproteins interact with the endothelium, the more times they're going to penetrate through the endothelium. And that process is pretty complicated too. So there's been proposal that science is burgeoning. I think the science of how ApoB containing lipoproteins interact with the luminal surface of the endothelium, it seems to be multifactorial. So there are multiple receptors on the surface of the endothelium. So it's a receptor-mediated translocation of the ApoB particle.
Because the word penetrate sounds very pathological, but if there is a receptor there, that would suggest to me that is there some type of need
it does.
For this flux of lipoproteins from circulation into the arterial wall.
Yes, and I would love it if you could tell me what that need is, because I've learned in my career, and I definitely think of LDL as the metabolic waste product that has served its purpose, which is to transport triglycerides out to the periphery, where there's clearly a need for triglycerides in the periphery. But why then would there be receptors on the surface of an endothelium for particles that are not carrying much triglyceride that enable their penetration into the intima?
So that's a question that kind of remains to be answered. But what we do understand is that when the concentration of these particles is higher, there are more of them that are becoming retained, getting stuck in the artery wall. So what do you think explains why they're retained and why a HDL particle that's also fluxing in there is not retained?
It's really a scientific question that's beyond the scope of what I know, but I know that the ApoB 100 protein has a strong electrical charge. And the thought is that there's an interesting aspect of this that actually finds its way into the clinic, and I'll tell you about that in a second. But that strong electrical charge and the relationship to the proteoglycan matrix of the intima. So under the endothelium, there's this, what they refer to as a proteoglycan matrix, and that's the stroma, that's sort of the goo that's below there, the acellular goo that sort of holds the artery together in the intima. And the interaction of this electrical charge from ApoB is what causes it to get stuck in. It's not permanent. There is some movement of ApoB containing lipoproteins out of the intima, but by and large, it's, they get stuck in and they don't get out. And while they're there, there's modification. So these particles can get oxidized. They can be modified by fatty acids in different ways. And then their modification enables them to be this trigger to the white blood cells that live typically just waiting for something to do, but that will live there in that intima. And that's what triggers the beginning of atherosclerosis. It's the penetration of ApoB containing lipoproteins, their modification, and the energizing or turning on of monocytes in particular that will then engulf the lipoprotein through a process known as phagocytosis. And then that monocyte, once it's taken up the lipoprotein, now has these ApoB containing lipoproteins inside of it. And when you look at them under a microscope, they look foamy. And so the pathologists refer to them as foam cells. And it's the initiation, the development of foam cells that is the beginning of atherosclerosis.
So that's the response to retention model kind of explained. Does that happen if in metabolically healthy people? Do you ever see someone present in clinic, for example, who has elevated ApoB and they have signs of atherosclerosis, but they don't have high triglycerides, they don't have insulin resistance, they don't have diabetes, they're not a smoker?
Well, I'm not a pediatrician, but I do take care of some patients with homozygous familial hypercholesterolemia who have almost no or no functioning LDL receptors and walk around with LDL cholesterol levels of 800, 900. I mean, those are extraordinary, and that's a rare condition. But those kids can sometimes have cardiovascular disease, heart attacks, death before age 15. So they're not smokers. They don't have high blood pressure. They're not diabetic. They are a unique physiologic condition because they have non-functioning LDL receptors. And if anything, you would think non-functioning LDL receptors might even protect them, because one of the receptors that enables the passage of ApoB containing lipoproteins through the endothelium is the LDL receptor. But it's it's a minor pathway for the movement of those particles into the endothelium. But that's one, crazy example, right? That's an extreme rare disease example. But we definitely see adults in our clinic who, they look healthy. They take good care of themselves. They don't have, high blood pressure. They don't have any signs of insulin resistance or visceral adiposity. They certainly don't have diabetes. They don't smoke. They may or may not have genetic factors. And they're not nearly as rare as those homozygous FH patients. I'll tell you, I have a listserv where I'll email my colleagues around the country who are in lipidology, and I jokingly refer to it as the case of the week. But the emails actually tend to go out like maybe once a month. My case of the week is becoming harder to generate. But every once in a while, one of us will pass out hey, I just saw this person who has these exact same features you have, and I couldn't discern any identifiable major risk factor for atherosclerosis, yet this person just came back from 3-vessel coronary artery bypass grafting after a heart attack. We see these patients. It's they're not rare. They're uncommon, but they're not rare. And so clearly, of the measurable things that trigger atherosclerosis, they don't have any of them.
Including elevated ApoB?
Oh, yeah. They can have totally normal ApoB levels. What would be rare is if those individuals had very low levels of ApoB or whatever metric you want to use to indicate low atherogenic lipoprotein predisposition. So they can have, you're not going to see those people come in who have an LDL cholesterol level of 40 milligrams per deciliter and an ApoB of 40. Like that I've never seen. I'm not even sure I've heard of it. But
is that because once you get to that low of a concentration, you're just taking out the I guess the initial spark? You know, it's almost like ApoB. I think we spoke on the phone, and I think you agreed that elevated ApoB is a requirement to some extent. It's necessary.
So ApoB, the ApoB containing lipoproteins are the building block for atherogenesis. If you don't have those lipoproteins in the intima, then the monocyte doesn't have anything to create a foam cell with. And so you don't get atherosclerosis. But I don't know whether this process is turned off entirely just because you have a low level. But I do think what's happening is that it's happening, even if it is happening, it's happening so slowly that clinically it never amounts to anything.
What about if we flipped that? Do you ever see someone who has a really high ApoB, but no signs of disease or disease progression?
Yeah, we see that more commonly, I would say. This is, the condition, atherosclerosis, requires exposure times time. So, for example, it's not uncommon to see a postmenopausal woman who throughout the first 50 years of her life has normal LDL cholesterol and ApoB levels and no other risk factors for disease, goes through menopause and has a tremendous increase in both of those metrics to levels where ordinarily you would think is going to be very harmful. But if you see that person at age 60 and they've really only had high levels and have been metabolically healthy their entire life, and they've only had high levels for a decade or less, generally those patients, when they come in as patients, they don't seem to have much, if any, or measurable atherosclerosis using the tools that we have at our disposal.
Yeah, often I see people kind of point to an example of someone with elevated ApoB that doesn't have atherosclerosis as a way of saying, see, ApoB doesn't cause atherosclerosis, but that would be similar to pointing to an example of someone who smoked cigarettes for 40 years who didn't get lung cancer and then saying, see, smoking doesn't cause lung cancer. It's like, no, smoking does cause lung cancer, but it's not going to cause lung cancer in everyone.
Right.
My go-to brand for all things protein and creatine is Momentous. To help reach my daily protein target, I complement my diet with 1.5 scoops of Momentous's chocolate or vanilla chai plant-based protein for 30 grams of protein and all essential amino acids, which supports muscle growth, hormone and collagen production, skin health, and recovery. I also consume 10 grams of Momentous' creatine daily to enhance energy production, muscle strength, bone health, and cognition, with studies now showing the benefit of creatine on short-term memory and intelligence. I'll do anything for a little extra brain power. Both products are NSF certified for sport. This certification is the only third-party certification program trusted by the NBA, MLB, Ironman, etc. NSF certification means you can rest easy knowing you're actually getting what's on the label and nothing more. So if you're interested in making a true investment in your health, why not join the best in human performance and be a part of the change in raising the bar on supplements? Our friends at Momentous are giving you permission to take care of you first this holiday season with exclusive early access to their Black Friday, Cyber Monday sale for all listeners of The Proof. Until November 25th, you can use the code LIVINGPROOF at checkout on livemomentous.com for 25% off all of your favorite supplements and receive a free gift of 5 nights of their best-selling sleep packs for orders over $75. That's code LIVINGPROOF at livemomentus.com through November 25th.
The lipid profile gives you access to two pieces of information and maybe more. I'm just sort of formulating this as it comes out, but it will tell me roughly what the exposure is of the endothelium to how much ApoB containing lipoproteins there are. But it also is a reflection on the metabolic status of the individual. So those who only measure LDL cholesterol and don't do a full lipid profile, they don't have access to that. Or similarly, let's say the concept of I'm only going to measure ApoB because that's the only thing that matters. And if I want to know the atherogenicity of someone's lipid profile, all I care about is ApoB. I'm not in that camp, but there are those who have said those things. If you don't have the full lipid profile, now you don't have any concept of the other things you can learn from a lipid profile. And you know that typically when there's insulin resistance and visceral adiposity, that you tend to see higher triglycerides and lower HDL cholesterol. Neither of those things are necessarily targets of therapy. I don't see a patient like that and say, oh, your triglycerides are high and your HDL cholesterol is low. Therefore, I'm going to do this thing to make your triglycerides go down and your HDL cholesterol go up. That's not how we manage the care. But I now have a red flag that says, whatever else you thought was going on, now you have a marker that says, this person's metabolically unhealthy. They have two of the key features of the metabolic syndrome, which is meant to indicate the presence of insulin resistance.
And then coming back to atherosclerosis, if ApoB is kind of like, another way that I think of this, and this is an analogy, so you might not like it and feel free to correct me, is if we think of ApoB as like a single match kind of lighting a fire, you can start a pretty big fire with wood and kindling, but it's going to take a lot longer than if you have like a blowtorch.
Okay.
And so this was an analogy that I've taken from someone that sent it to me. I thought it was quite good. That blowtorch being, having elevated ApoB, but in the presence of poor metabolic health and having insulin resistance or, being a smoker, overweight, high blood pressure.
Well, inflammation is a key feature of atherosclerosis. So I think thinking of ApoB as the thing that's on fire, I don't like that analogy because it's not the thing that's on fire. It's the white blood cells and the cytokines, the inflammatory chemicals that are being released by the white blood cells. That's where the fire is. The fuel for this process is the ApoB. You can't make those foam cells without the ApoB containing lipoproteins. So just I'm open to however you want to make this analogy.
I think the analogy was that ApoB was starting the fire, was the match in the initial analogy. Yeah. But right. You're saying it might be better put as a fuel.
I think so.
Okay.
I think it's the fuel that drives this. And so you need...
So if it's the fuel, what's lighting it?
So that's a fantastic question. So these ApoB containing lipoproteins, they come in lots of different flavors. And there is different atherogenic potential between them. So the ability to light this on fire is different based upon which is the predominant ApoB containing lipoprotein. Because in order to light it, you need the monocyte to say, hey, that's not supposed to be there. I'm going to do what the immune system does when things are where they're not supposed to be, and I'm going to take care of that.
So this is back to retention.
Yes. Well, no. Once they're retained, there are different versions of ApoB containing lipoproteins. So there's LDL, and there's different. There's even a whole subsets of LDL, but there's also triglyceride-rich lipoprotein remnant particles and lipoprotein a. 3 different families of ApoB containing lipoproteins that act as that are the fuel for atherosclerosis.
But you're saying the response to those being retained could differ?
Yeah.
Based on what kind of characteristics? So
the fatty acid characteristics, so that the actual lipid content of the particles is different. The lipoprotein a in particular has the ability to carry what are known as oxidized phospholipids. I don't know why. And I don't know why LDL doesn't have the same carrying capacity. Perhaps one of your LPA experts who comes on can answer that question better than me. But the ability, that may be the main thing that makes LPA more atherogenic than LDL particles on a particle for particle basis. And triglyceride-rich lipoprotein remnants too have a much higher fatty acid content, and fatty acids can trigger all kinds of inflammatory reactions. So triglyceride-rich lipoproteins are also more atherogenic on a particle for particle basis.
There's a lot of variables here, because you could have two contexts, same ApoB, but the fraction of VLDLs, IDLs, LDLs, LP(a) are different. That's one variable, and you kind of, I think that's actually one of the better arguments that I've seen come from proponents of a low carbohydrate ketogenic diet who are unsure whether elevated ApoB in that context is the same in terms of the risk that it poses as a context of, say, the average American who has this underlying poor metabolic health. And the point that I see them making that I think is interesting is that someone who has poor metabolic health, often you'll see ApoB go up. There's excessive kind of triglyceride production in the liver, and you get an increase in these VLDLs that we're speaking about. Triglycerides are high. They have insulin resistance. They often have more of these VLDLs, right, compared to the person who is metabolically healthy that adopts a low-carb ketogenic diet. Their ApoB goes up, but it's mostly LDLs, not these VLDLs, is my understanding of their position. And I'm not sure whether they're directly saying that it's the difference in the kind of ratios that is the problem, or just that elevated ApoB being increased in the average American is more of just a marker of poor metabolic health, which is really driving the risk for atherosclerosis.
I don't know. A lot of what we know about this is based upon epidemiology. And while genetically humans have not changed much in the last 10 to 30,000 years, we are biologically very different from a generation ago or 2 generations ago. So at a time when atherosclerosis was at its peak, we didn't see the amount of obesity and insulin resistance and diabetes that we see now. But 45% of adults were smoking. And so we had slim smokers where eating a lot of steak and having very high LDL cholesterol, and we had peak levels of atherosclerosis.
But presumably pretty damaged endothelium.
Yeah.
From smoking.
Yeah.
Right?
So that was the sort of the phenotype, the classic phenotype that the cardiologists were taking care of with, obviously, that wasn't every single person with athero, but that was sort of who you think of who was having heart attacks in the 1950s, 60s, and 70s. And then since then, we've shifted as a population, not just the United States, but globally, to fatter, more insulin resistance, a change in the lipoprotein profile. And now, I think the last statistic I saw was that 14% of adults smoke cigarettes. I mean, that is a public health amazing outcome to go from 45% to 14%. Huge change. And yet, some of the gains that you would expect from less smoking have been offset by the increase in obesity and insulin resistance. And so we have this different physiologic circumstance. And most of what we know from epidemiology is based upon looking at populations and where they are. And we're always a decade or 2 behind in this process. So where we're going and what that means, well, what if we take this whole population that's not smoking anymore and we slim them down by whatever mechanism, and you figure out a way to make them less metabolically sick with insulin resistance specifically, what's going to be the consequence on us as a population? One would predict great improvements, right? But we haven't played that out yet. And we'll see whether that kind of thing can change. So all we have are these individuals who can follow incredibly disciplined programs to improve their metabolic health by not walking into every Burger King that they see and not drinking Pepsi Cola and all the other things that seem to be driving so much of the insulin resistance and obesity. They are segments of the population, and they are fewer and far between than I wish they were. But we can learn from them, and we may learn that, boy, if you're metabolically healthy, even if you have a high level of LDL cholesterol, maybe you're not going to be at the same risk for cardiovascular disease, but that's going to take some time to figure that out.
How do you manage that clinically now? If you have a patient that presents that, I think we also have to add here that something I think more and more of is that there are a bunch of people that have adopted like a keto or a low carb diet and seen a significant increase in ApoB, and they have lost a lot of weight. And so their metabolic health has improved. And something that I think is often not appreciated, and I'll throw this to you to see what you think of it, is that they may have restored their metabolic health, which is amazing then and there. But if you've had 2 or 3 decades prior of poor metabolic health and potentially damage to the endothelium, is there a kind of residual risk in that person has, whereby this extremely high ApoB, could be quite dangerous?
Yeah, it could be. I think there's all different iterations of how that could play out, and it is certainly possible that if you have somebody who has significant atherosclerosis as a consequence of their metabolic condition before they made significant metabolic changes, that they could be pretty susceptible to advancement of their disease if you keep feeding them large amounts of LDL in the circulation. I don't mean feeding them, but if the arteries are fed large amounts of LDL. So we do get this in clinic pretty regularly. It's common for people to change to a low carbohydrate or very low carbohydrate diet. And oftentimes what that means is they've replaced a lot of the sugar and refined carbohydrates with maybe protein sources that contain higher levels of saturated fat. And when you see that, that's when you tend to see a bump in the LDL cholesterol and sometimes the ApoB. And then, of course, there's that weird subset of so-called lean mass hyperresponders that, may represent the very unique change that takes place that still we need to learn more about. But I think maybe at the extreme, that's what you're asking about. They are people who on a ketogenic diet have a major change, not just in their LDL cholesterol, but also their triglycerides drop, precipitously. Their LDL cholesterol goes up, their HDL cholesterol goes up, and their ApoB goes up. And the question is, are they in jeopardy of atherosclerosis, even though they don't have insulin resistance? And the response to retention hypothesis would suggest that they are, because they have so much ApoB in circulation.
What kind of context in clinic would you be kind of seeing where someone has significantly elevated LDL cholesterol? Let's say, would you call 150, 160 significantly elevated?
Yeah.
Yeah. So let's say they have 150, 160,
okay.
right? Milligrams per deciliter. And let's say you measure their ApoB as well.
Yeah.
And significantly elevated, so there's no discordance, which we might get into. We haven't quite defined that yet. Is there a scenario where you are okay, not to recommend kind of lipid-lowering therapy or dietary modification to lower that, where they're just low risk overall, so it's not a concern?
Yes, for sure. So I definitely prescribe a lot of medicine. I think your first words when we started was, "I hope you brought your prescription pad." So
I've had people tell me that based on my history, and we'll come to that I should be knocking my ApoB down to 30 milligrams per deciliter.
Yeah,
that's just a view from some people. So we can workshop that.
Yeah, we'll definitely get to that. So who you treat with medicine should be based upon, and I don't want to come off sounding cliche, but it should be based upon a clinician-patient decision. there are certain examples where the evidence is what at the American Heart Association would refer to as class 1, level A evidence. And when I have a patient who has a class 1, level A indication to take medication, I tell them that. And I don't necessarily use that phraseology of class 1A. I'll explain to them, this is what we would call an arm twisting recommendation. I would say, you have incontrovertible evidence that if people with your features are more likely to, or less likely to have a serious cardiovascular event if you take this drug versus those who take a placebo, all things being equal. And so we have a handful of circumstances where somebody is in that condition. When the risk for cardiovascular disease and the plaque burden is less, the short-term benefit of taking medicine to lower LDL cholesterol and ApoB is less clear. The evidence is less strong. We don't have randomized placebo-controlled clinical trials in people at low risk treated for 30 years. But there are people who have low short-term risk for events like heart attacks and strokes, who may not have significant atherosclerosis now, who personally have a preference to not use medicine until their risk is greater and they have more of a plaque burden. And I'm totally comfortable if my patient says to me, gee, doc, I really don't want to take medicine now. The words I use is I say, no problem. I will sleep fine knowing that you are not on medicine because your short-term risk is low enough to justify that approach. But I will tell you, the longer you let your LDL cholesterol to be elevated and your ApoB to be elevated, the more atherosclerosis forms. And if we wait too long and wait until you have more significant atherosclerosis that's observable with imaging, for example, then we probably have to use a more intensive strategy. If you start early, you can use a less intensive pharmacologic strategy to achieve
like you have to
outcomes.
play a bit of catch up if that fire has already started.
Yeah. And Kevin John Williams wrote an editorial recently, or maybe it was a review, where he referred to it as too much too late. And so, catching people early so that you don't have to throw the kitchen sink at them and you can manage care, with less intensive approaches, which most of us would prefer for ourselves.
Is that usually lends to less side effects? Is that one of the benefits?
In general, when you're talking about statins, that's the case. I don't think that's necessarily the case when you're introducing, PCSK9 inhibitors, which, have a, very clean side effect profile. And so some of what I have to say has to be couched in those terms, that when you're talking about statin drugs, even though I don't have any safety concerns, there are some tolerability concerns, as everybody who's ever been to a cocktail party knows. This is what old people talk about at cocktail parties.
When you're trying to determine the risk of having a cardiovascular event for a patient that's sitting in front of you, and I know in this paper you spoke about a 10-year kind of risk estimation or calculation. Is that usually what you're looking at, the risk of having some event in the next 10 years? Because I would think, certainly for someone my age, I'm interested when it comes to the decision-making process of should I take a lipid-lowering drug, what's my risk of having a heart attack in 15 years, 20 years, 30 years? What can I do now that's going to stop me having a heart attack, before I'm 70, 75?
A lot of the conversations we have are based upon the information that's provided in things like guidelines and which are recognized by insurance companies and which as societies we have to acknowledge, even if we think that biologically or philosophically there's more to it than what we can say. It stems from an approach that is described as evidence-based medicine. I'm sure you're familiar with that concept. But I'm old enough at age 57 to remember a time when people would have conversations about the rise of evidence-based medicine. And that differs from how we always took care of patients before my generation, which was a sort of tutelage. A clinician learned from their master who learned from their master. And it was a traditional approach, almost more like an Eastern approach. It was certainly there was science and evidence. My generation didn't invent evidence-based medicine, but they brought it to the front to show that you can't just use your best judgment and the biology and you show me that drug X works better than placebo before you start telling me to take drug X. And the tools at our disposal are the best tools are randomized placebo-controlled trials. So the first set of cholesterol national guidelines that was strictly adherent to evidence-based medicine with that, prioritizing randomized placebo-controlled trials and meta-analyses of the same was the 2013 ACC-AHA cholesterol guideline. It's not that the NIH that wrote the guidelines before then didn't use evidence. They did. They used lots of evidence. They used RCT evidence, and they also used meta-analyses, but they also used angiographic data. They used studies that had intermediates. They used genetic information, clinical epidemiology, and expert opinion to formulate these ideas. And in around 2011, the Institute of Medicine actually set out some guidelines on how to write guidelines. And they said, before any organization writes a guideline for how people should be practicing medicine, they said, these are the standards that should be followed. And they set the bar very high. They said, RCT evidence and meta-analyses of the same, it should be at the fore, and clinical decisions should be based upon that. And the American Heart Association, American College of Cardiology stood up and said, we can write that guideline. We can do a good job reviewing the data, reviewing the evidence, and setting out how doctors should manage care. And they issued that set of guideline in 2013. But in 2013, the only big RCT evidence for ASCVD risk reduction with medication came from statins. You had to go back to the 1970s and 1980s to find evidence with cholestyramine and gemfibrozil. With a stretch, if you use your imagination, you can say niacin also. But that was sort of antiquated data at that time. And by 2013, we had numerous clinical trials showing that statin drugs reduce ASCVD risk. And so in 2013, the evidence could only support using that kind of approach. Those clinical trials are all, 3 years, 5 years? We don't have 30-year clinical trials with those drugs. Same thing with risk calculation. So when you're trying to estimate what someone's risk is and whether they qualify for medicine using this strict evidence-based approach, well, how were the clinical trials done? Well, how did you get into the clinical trial? You had to, some of them were so-called secondary prevention trials, meaning you had to have established atherosclerotic cardiovascular disease. If you've had a heart attack, a stroke, and stents, bypass, whatever your event was, that qualified you. And then there were primary prevention studies, people who have never had cardiovascular event, but they oftentimes had qualifying factors like an LDL cholesterol above a certain range, or the presence of some other factor like diabetes, or multiple risk factors, to be able to get into the study. So that's how the clinical trials were designed. And so when you're writing a guideline that's based on the evidence, you have to base it on how the clinical trials were designed. And
so there's going to be plenty of individuals that you see in clinic that don't fit into those perfect buckets.
Exactly. So that set of guidelines did something else that was really useful, which is they introduced some epidemiologic evidence using something called the pooled cohort risk equation, which was a much more inclusive body of evidence to support how to estimate risk that went beyond just clinical trials like the Framingham study, which had was mostly white and population and didn't have quite the ethnic diversity that you could get from a broader scope. And so the pooled cohort risk equation was a big improvement as a risk predictive tool, but it still primarily provides us with a 10-year predictive tool. There's a 30-year extension to that a lot of us use. And so if you came to me, I would consider using a tool like the pooled cohort risk equation with the 30-year extension and think about you in the long run that way. And they've even improved upon that. Something called the Prevent risk calculator.
How do you feel about the whole cholesterol years concept? Have you seen that, where it's kind of akin to pack years with cigarettes, so kind of lifetime exposure to cholesterol? And I can remember a chart that I've seen in a paper, and it's when you go over a certain sort of 1,000 milligrams per deciliter of cholesterol, then you're at a stage where I believe you may start to see symptomatic atherosclerotic cardiovascular disease. Have you seen that graph that I'm talking about?
I have. I think conceptually it makes a lot of sense. I actually have a graphic that I use in my teaching that sort of uses the same concept, but I think in the clinic it doesn't really resonate for me. Partly because I don't know what their levels have been that whole time. I would have to extrapolate based upon where they are now. People, LDL cholesterol levels don't change that much over time, but they do change. They change with puberty. They change throughout adulthood. There's a gradual increase.
And menopause, like you mentioned.
Big changes. And by the way, when I say LDL cholesterol, I'm also including ApoB.
We're going to come back to ApoB, which is meant to be what the
I know
the focus
that's
is.
Okay.
We kind of digress a little bit there, but when in clinic, would you not order ApoB? Is there ever a scenario where LDL cholesterol, non-HDL cholesterol, HDL cholesterol, and triglycerides tells you everything you need to know, and there wouldn't be any kind of extra information that you would get from ApoB that would change your kind of clinical management of that patient?
Yes, I think there are scenarios where I don't need to know somebody's ApoB. I have to think about when that is. Mostly, my first thought about that is that it's after I've already established that their ApoB matches their LDL cholesterol. So when it's so-called concordant with their LDL cholesterol. So if I can learn that from the LDL cholesterol, the current standard now is that if I want to know somebody's ApoB, I have to order that as a separate test. And every time I order a separate test for an individual, I generate a bill, right? The lab is going to charge that person and their proxy money to do that measurement. So someone has to pay for that.
In what percentage of the population would you say ApoB correlates really well to LDL cholesterol?
I think the number's around 75 to 80%.
Okay.
That the discordance rate is somewhere in the, and maybe I overstated that. I think it's somewhere in the 1/3 kind of range. I think I maybe overstated that. So maybe 60 to 70% is concordant.
And so discordance in that, say 25% or whatever it is when you measure their LDL cholesterol, it's a certain number. You then measure ApoB, and that ApoB is dramatically lower or higher than you would have predicted.
Discordance is not well defined in the medical literature. I think I know it when I see it, but there's a lot of different ways that you can describe it. When there's a major discordance, it's obvious, but there's also minor discordance. So the concept of concordance or versus discordance is based upon population-based tables. So in our paper, we looked at tables from 3 different data sets. The first one is the National Health and Nutrition Survey, the NHANES, and using data in untreated adults over the age of 18 between the years of 2005 to 2016, because that was the database that we had. And in untreated individuals, you can form a data table of what the range of LDL cholesterol is in that population. And it's a survey. And if I remember the number correctly, it was something over 12,000 individuals in that data set. So the range of LDL cholesterol, it may not, you may not capture anybody with like rare diseases or anything, but it's meant to be representative of the society at large. And then you get a similar range of ApoB. So that data set, we had ApoB levels on all those individuals as well. And you can see whose level is in the 5th percentile for ApoB and the 5th percentile for LDL cholesterol. You can see who's in the 50th percentile for both. You can see, what the numbers are for the 75th percentile. And so you can create a table and put them next to each other and see if they line up. So we made a table using deciles. And if somebody's in a different decile, you could, I suppose, refer to them as being discordant. So if you're in the 20th percentile for LDL cholesterol, but the 30th percentile for ApoB, you're discordant.
Mildly.
But it probably doesn't matter biologically. But if you're in the 20th percentile for LDL cholesterol and the 80th percentile for ApoB, it probably does matter.
So the issue is I'll get you to elaborate on this. There's probably a couple different issues that could arise in clinic. But I come in to see you, I show you my LDL cholesterol. Let's say it's 80 milligrams per deciliter. And you're thinking, and let's say I'm untreated. You're thinking, well, that's not too high. Could be lower, but it's not crazy high by any means. You don't measure my ApoB. You just assume that it's correlated. Meanwhile, my ApoB could be 120, 130. Yeah. So they're discordant. And because ApoB is what really is determining risk, not LDL cholesterol, I'm now someone who's untreated with higher risk than you thought.
Exactly. That's one of my greatest fears, is that we have untreated patients who we're undertreating because we think they look fine. And that discordance, if you don't measure ApoB, you don't even know that that's the case. You can also do this with NMR and ion mobility and look at LDL particle number. But in the, I don't want to get too much into that because I know less about measuring particle number than I do about ApoB. But ApoB is a well-validated, reproducible, inexpensive way to estimate the number of atherogenic lipoproteins. And so we have these now we have these population-based tables that we can really look at that, and we can do what are known as discordance analyses. Definitely not my expertise in how those are done, but there's a lot of different ways that discordance analyses have been done. You can look at above the mean versus below the mean and call that discordant. But that also means that if you're in the 49th percentile for one and the 51st percentile for another, you're discordant. And that doesn't distinguish between 20th versus 80th, unless I'm sure there's some parameters to how that's done too. But that's one way, is just above versus below the mean for numbers.
Guys, we have to talk about this, a total game changer in the world of sleep technology. 8 Sleep and their mind-blowing Pod 4 Ultra. It's like the superhero your mattress never knew it needed. You can access their Black Friday offer today using the code THEPROOF to get up to $600 off your Pod 4 Ultra purchase when bundled. This is their highest offer of the year. But first, let me tell you what the pod is and why I think this is a must-have for anybody who wants to sleep better. Lately, I've been making a serious effort to upgrade my own personal sleep game. And I'm not talking about fluffing up some extra pillows here. I'm talking about high-tech wizardry with the 8 Sleep Pod 4 Ultra. A mattress cover so advanced, it's basically the James Bond of bedding. It turns your regular bed into a sleep optimization powerhouse. We're talking next level temperature regulation, elevation control, and biometric tracking that'll have you feeling like you're living in the future. My favorite feature? Thanks for asking. The temperature regulation. 8 Sleep's autopilot uses machine learning, yes, your bed is smarter than you know, to analyze your sleep patterns and adjust the temperature from a cozy 55 degrees Fahrenheit to a toasty 110 degrees Fahrenheit. It's like having a sleep butler who knows exactly when you're too hot or too cold, without the awkward small talk. When you wake up, the 8 Sleep app greets you with a full rundown of how you slept, along with important health stats like resting heart rate, HIV, and breath rate. Basically all the info you never knew you wanted, but can't live without now. A personal sleep coach, minus the yelling. Since using the 8 Sleep Pod 4 Ultra, not only do I feel more rested and energetic, and I truly do, but I've also noticed my overnight heart rate has dropped by about 5 beats per minute. If you're ready to upgrade your sleep and recovery, head over to 8sleep.com/theproof and use the code THEPROOF to get up to $600 off your Pod 4 Ultra purchase when bundled. Oh, and the best part, you get 30 days to try it out. And if for some reason you decide you don't like sleeping like a baby, you can return it. But let's be honest, you're probably going to keep it. I mean, once you go 8 Sleep, you never go back. Shipping available to many countries worldwide, so no excuses. Head to 8sleep.com/theproof for details. Does it really matter if you're discordant or not, the label, or is it just about getting LDL cholesterol and ApoB to some desirable level based on who you are?
Oh yeah, thank you for cutting right to that, because that's actually where I was going, which is none of that really matters. What I will tell you is that all the different discordance analyses that have been done have confirmed that if you're trying to predict who's has more residual risk on treatment, ApoB is a much better tool for doing that. Whether you're using the older Friedenwald formula for calculating LDL cholesterol or the newer Martin Hopkins or Samson NIH formula, it doesn't matter what LDL cholesterol formula you use, ApoB is still going to outperform LDL cholesterol.
So that could arise for someone who's being treated with lipid-lowering therapy. So it's different context. They're treated with some level of intensity. LDL cholesterol gets to goal according to the guidelines. But again, if ApoB is not measured, you might miss that there is discordance in this individual and ApoB is higher than where we would want it.
Yeah. So that scenario. So we looked at that data. Also, we used data from 2 large clinical trials, something called the Improve It trial, which was the ezetimibe study, and the Fourier trial, which was evolocumab, the PCSK9 monoclonal antibody study in people with stable ASCVD. And so, we had a lot of patients in those 2 clinical trials, and we could do, we could create the corollary LDL cholesterol versus ApoB tables and show the linear relationship between those 2 things and the presence of discordance in treated patients. It's not the same line exactly as the line that we created in the untreated patients. The relationship between treated and untreated patients is different. Conceptually, I think what's happening, and Alan Snyderman helped talk me through this, and I think this makes sense, is that when you treat patients with the medicines that we use, all of those LDL receptor modulating therapies, statins, ezetimibe, PCSK9 therapies, you upregulate LDL receptors, you selectively remove LDL particles that are more cholesterol enriched compared to cholesterol depleted particles. So the LDL cholesterol tends to go down disproportionately compared to the ApoB on treatment. So the linear relationship in treated versus untreated patients is different enough that when you look at the linear relationship, they're actually 2 different lines. And Nick Marston, and one of the authors on our paper, really helped us put together this with Maureen Sampson from the NIH, who helped us put the NHANES data together. And when you put those 2 data pieces together, you do see that there's a difference between them. And so the consequence is that when we had these data sets, we could have created 2 different types of discordance tables to look at. But man, this is complicated enough as it is. So what we tried to do is just converge those data sets of treated and untreated patients, recognize that we don't have to be precise here. We want to, the message needs to be, there's a possibility that you can have discordance. When there's discordance, trust the ApoB more than the LDL cholesterol. And we created some thresholds that are based upon the guideline-based LDL cholesterol thresholds by using this data set.
And so the idea is, if there is discordance, there may be this residual risk that is posed by this elevated level of ApoB. You treat ApoB to some sort of target level based on someone's risk, and then, and I believe from reading the paper, this is where there's a gap in the research, but the presumption now is that treating that ApoB in that scenario would help attenuate, reduce that residual risk and lower events even further.
That's the idea. And I'm under no pretense that we eliminate atherosclerosis in those people, and no pretense that that is going to eradicate all of the risk, but it should eradicate as much of the risk due to lipid and lipoprotein levels as possible.
So how does the clinician who's listening to this, how do you manage this? Someone comes in to see you for the first time, are you just ordering LDL cholesterol and non-HDL cholesterol, which are currently in the guidelines, and there's evidence for treating those and reducing events, and you treat those, and then later on you go and order ApoB? Or do you just skip all of that, order ApoB at the beginning, and just get ApoB to goal, and in doing so, non-HDL cholesterol and LDL cholesterol will follow suit?
Well, so remember I mentioned that 3 months ago, my entire practice now is clinical lipidology and preventive cardiology. So all of my patients have been referred or have self-referred. And I think there's a different relationship when someone comes in just to pay attention to their cardiometabolic and lipid status than someone who's coming in with a sore elbow and you say, oh, gee, I see you have a pack of cigarettes in your pocket. Rather than talking about your elbow today, can we talk about your cardiovascular risk? So two completely different contexts when you're talking about primary care versus a lipidology practice. In my practice, every time I see somebody for the first time, I like to see a lipid panel and an ApoB done simultaneously. If they've never checked their LPA before, we'll also use that opportunity to check their lipoprotein (a). And if they're not on treatment, even better, because now I can learn about their underlying condition and understand a little bit more about whether or not they have a lipid syndrome, because I'm always wearing my lipidology hat. And so,
but does that get a little harder to pick up when you start to, do things get masked when you start to see, when you're looking at someone who's already on lipid-lowering therapy?
Yeah, it kind of does, because the lipid syndromes are characterized by which lipoprotein is elevated. And if you're taking medicine to treat that already, you've already addressed part of that problem. So you may not identify the syndrome if you don't have, their pre-treatment levels.
Yeah, I guess that would be a nice scenario would be to have a patient come that has all of their historical blood test before starting.
It definitely makes I learn more. The more data, the more I learn. And so in my patients who, so the real time when I do want to check the ApoB is first evaluation, new treatment and response to therapy to make sure that both have responded adequately. And anytime I change treatment, once I've established that person now has concordant results, then I don't think I need to keep ordering a separate test. If I got to design things the way I wanted, I would just add, I wish an ApoB were part of a lipid panel. It's, the current lipid panel is total cholesterol, triglyceride level, HDL cholesterol, an LDL cholesterol calculation, and sometimes they'll report a non-HDL cholesterol, but you can do the math yourself too.
I understand that a large percentage of people who have this discordance between ApoB and LDL cholesterol and ApoB and non-HDL, which we haven't really unpacked, so we'll get there, are people with type 2 diabetes, high triglycerides. But I also understand from a paper that you referred me to yesterday that it is possible for someone who presents as healthy, lean, metabolically healthy to also have discordance where they might get their LDL cholesterol measured. It looks good, but their ApoB is sky high.
Yeah, so Anne-Marie Navarre is the lead author on this fantastic ApoB paper that was published a month or two before our consensus statement was published. Kevin Mackey sent me the paper when it first came out. And I have to say that when it came, I was so engrossed in doing the finishing touches on our paper. My response was, I couldn't read it at the time, and I just wasn't ready to crack it open. But I think we all were inspired by the same thing, which is, decades of Alan Snyderman teaching us about the importance of a metric that demonstrates the number of particles as opposed to the lipid content of those particles. They looked at a lot of the same literature and they drew a lot of the same conclusions themselves. And they made a bigger point of this concept of discordance in people who are more metabolically healthy or less metabolically sick, that discordance phenomena can occur. In our paper, we didn't break it down that way. We didn't look at that particular evidence, but I know that exists, and I know, and they reported it beautifully that while it's probably more common in people who have insulin resistance and hypertriglyceridemia and visceral adiposity and diabetes, it's not exclusive to that population. So I do like to see ApoB levels and lipid profiles on all my patients whenever possible because of that phenomenon.
And for someone who's listening, who's thinking, oh, I thought non-HDL cholesterol was very similar to ApoB, or at least a better predictor than LDL cholesterol, how would you explain the difference between LDL cholesterol, non-HDL cholesterol, and ApoB in terms of predicting risk?
Non-HDL cholesterol is a fantastic tool. It works a great deal of the time, but you can get non-HDL cholesterol and ApoB discordance as well. And when that occurs, I think the evidence more strongly supports using ApoB, but it's not a slam dunk. I think there's some evidence that would suggest that non-HDL cholesterol has some advantages over ApoB. I come down on the side of if there's discordance between the two of them, I tend to prefer ApoB. And I hate to introduce, yet another possible, scenario that's equally confounding, which is LDL particle ApoB discordance. And that drives me crazy because some of our patients end up doing NMR and ion mobility testing for LDL particle number. And I think I have this like fancy high-tech test, looking at LDL particle number, and that's got to be the best test. But you'll still see ApoB discordance with those individuals.
Where there's presumably more VLDLs and IDLs or less of those, and somehow that's affecting ApoB.
Yeah. And I don't know actually the reason for that. I mean, we could probably work through it, but I'm told by some of my colleagues who are deep in lab science expertise that in that circumstance, the technologies that we use that look so valuable, NMR and ion mobility, actually are not as reliable in that circumstance, and that ApoB actually outperforms LDL particle in that circumstance. I can't cite the studies. This was based upon internal conversations with some of the colleagues I trust very highly.
Okay, so if someone's not seeing a lipid specialist, doesn't have a significant history of cardiovascular disease, is just doing a regular yearly blood panel, ApoB would be a nice to have, but non-HDL cholesterol is going to be pretty good at that stage.
I think it is pretty good. It's quite good. I'll rephrase that. It's quite good. The National Lipid Association wrote a paper in 2014 actually suggesting that non-HDL cholesterol be the primary target of therapy and that LDL cholesterol should be the secondary target of therapy. Meaning, once you fix the non-HDL cholesterol, sure, look at the LDL cholesterol then. And in the number of people who will need to do anything different at that point is so small that you're probably not making a difference. And that's why prioritizing non-HDL cholesterol.
That's good for the section of the population that are not sort of at a intermediate or moderate high risk of cardiovascular disease, given that I think ApoB tests are becoming more accessible, but they still can come with a little bit of a cost, which creates an accessibility issue for certain people.
Yeah, they sometimes get rejected. I'll get a message from a patient saying, hey, that test that you did 6 months ago, it won't be 6 days ago. It'll be 6 months later. They get a notice that test that I ordered on them 6 months ago was, rejected, was denied by the insurer. And they usually refer to it as an experimental test. So one of the things that we felt was important in writing this consensus statement was to make it clear this is not an experimental test. This is as close to done science as we can get. This is a highly validated, reproducible, high quality test that demonstrates residual atherosclerotic cardiovascular risk due to lipid and lipoprotein abnormalities. So we made that pretty clear in the consensus statement. And I hope clinicians around the country don't have to write appeals for authorization for tests as much as they used to. But if they need to, they can use our paper as a reference since it comes from the National Lipid Association.
What do you think is required for ApoB to take the next step and be included in kind of AHA guidelines as a treatment target?
You know, the AHA, ACC, multi-society cholesterol treatment guideline writing teams are complicated. And, you know, the level of evidence has to be reviewed by committee. There's a lot of people have to all agree on the same thing. And the standards have to be set. I don't know the answer to that question, but I think that there is the pendulum is shifting that way based upon the level of evidence and conversations I've had with colleagues. And but ultimately, I think that's going to remains to be seen.
Yeah, I was going to ask you that. What's the feedback been like from colleagues since you've published this paper? Do you feel any resistance towards this kind of recommendation to start taking ApoB seriously, or is it, you know, pretty much universally being accepted as the better predictor for atherosclerotic cardiovascular disease than non-HDL cholesterol and LDL cholesterol, and therefore wise to order it when accessible for a patient?
I haven't gotten a ton of feedback about the paper. All of it's been positive. No one has said to me, I completely disagree with you. ApoB is useless. No one has said that. So I'll take the silence as it's not silence. I got plenty of feedback that said, great paper. You guys did a great job. I really appreciate you creating these tables and the figures. It's been very helpful. I'm so glad to have this resource. But I haven't gotten any of the negative feedback. So I think I'll take that as people agree.
And within your group that was writing the paper, was there pretty much universal agreement on the things that you included in the report?
Yeah. I mean, I hate to say that because did you really do something good if everybody's in agreement? Like you need to introduce, I mean, you like to have people who have a disagreement and bring a different, you know, approach to this. And we had plenty of conversations and plenty of opportunities to add more information. And everybody was like, yeah, this is great. Let's just tidy up the wording. Let's make sure that we say this the way we want to say this. And this was, yes, it was a handpicked group, but it wasn't a handpicked group of people who are on Team ApoB. This was a handpicked group of people who have contributed to the scientific literature, to the lipidology literature, who are willing to say, hey, what you're saying is stupid. And, you know, I'm smiling because I'm just thinking of some conversations we had while we were making it with some of my colleagues who were willing to say, hey, what you just said there was pretty stupid. Let's fix that. And they didn't say it those ways. Everybody was collegial and nice to each other. But there was no clash. There was widespread agreement that, yeah, ApoB is the thing.
I've seen, and you get this with anything, if I've seen any resistance online, I've seen, you know, people kind of accuse Big Pharma of just finding another way to prescribe more lipid-lowering therapy. What would you say to the person that thinks this is the pharmaceutical industry just trying to influence clinicians so that they're prescribing more drugs?
Well, I can tell you that our analysis also pointed out the times when you're going to prescribe less drug when you have high LDL cholesterol and low ApoB. And even though we didn't do a quantitative numerical analysis of the number of individuals who are affected by discordance, you know, when you eyeball the charts, what you're left with is a conclusion that the number of people on drug is going to be roughly the same, because you're going to treat more people more aggressively at the lower end where there's discordance and high ApoB and low LDL cholesterol who need more intensification of therapy. But there's going to be some people who their LDL cholesterol may be a certain thing, but their ApoB is quite low and you're done. And at the higher end, people with higher levels of LDL cholesterol, but low ApoB don't necessarily need pharmacotherapy, assuming that they don't have significant atherosclerosis.
So there are cases where you can defer.
I think so.
Treatment.
Yeah, just like you would with LDL cholesterol in people at low risk. You would defer treatment if their ApoB is low and they are at low risk, meaning they don't have evidence of significant atherosclerosis. Remember, if there's athero present, significant enough athero present, regardless of whatever measured variables you're looking at, we use LDL lowering therapy because LDL lowering therapy reduces the risk for bad outcomes in people with significant atherosclerosis. So,
right, but if you're someone that doesn't have atherosclerosis, has high LDL cholesterol, and physician recommends to lower that with a lipid lowering therapy, that's an interesting context to say, hey, I might check my ApoB before I start this prescription.
Totally agree. And when making that kind of recommendation, someone who looks like they're at low risk, has no, we didn't talk about how to identify whether somebody has atherosclerosis, but there are different tools for that. You don't see any signs of atherosclerosis, then the response when someone to the clinician who says, you should treat this anyway, the response to that should be, do I have to treat it now? Can I delay that? I know I'm just trying to minimize my exposure to medicine. All things sort of point to me being at low short-term risk, and maybe my 50-year risk is significant. But maybe as I get closer, maybe can we wait a decade? Can we wait 20 years? Can we monitor my progress along the way and change our plan if we start to see something changing?
So if you image someone, and we can go through what that might look like, and they do have atherosclerosis, they have elevated LDL cholesterol, is that person automatically classified as borderline to intermediate, high or very high risk based on just the presence of atherosclerosis?
Well, there's, we designate the presence of atherosclerosis differently. We use the term plaque. So plaque is a quantitative measure of atherosclerosis. Everybody in this room right now has atherosclerosis, but not all of us necessarily have plaque. So you can have sort of a pre-plaque where this process is going on. It's a fatty streak, but it's not quite raised to the level of plaque. So there's a quantitative difference. Some of our tools can distinguish between those things. But if you're in this phase, if you're in a stage in your life where all you have is fatty streaks, sure, you can definitely treat that with medicine. But the urgency to start medicine to treat that is less because the short-term risk is less. But if the individual who has that says, I don't like that I have that, I want to fix this, one of the tools at your disposal is reduce the LDL. And you can reduce it with medicine or find some other mechanism to reduce it. But it's not an arm-twisting class 1A guideline-based recommendation to treat somebody.
And you would pick up the fatty streak and plaque with a CT angiogram?
No, a fatty streak requires autopsy.
Okay.
So
right.
We generally don't do that with our patients. So
well, that makes sense because I think I've read some studies where they reported that in infants.
Yeah.
Right, that were I think killed in the car accidents.
Exactly. Yeah. The PDA study is an old study that used autopsy reports of pediatric aged individuals and adolescents and showed the presence of atherosclerosis in youth. And it's it's horrifying, but it is evidence that tells us that atherosclerosis starts early and is ubiquitous. And but so we don't treat everybody with atherosclerosis. But you ought to treat everybody who has plaque. So the national guidelines characterize individuals in 4 different ways. Are you familiar with this?
No.
The 2013 cholesterol guidelines refer to them as statin eligible treatment groups. The 2018 guidelines carried them forward. But now that we have evidence from non-statins and their ability to reduce risk with other LDL lowering approaches, can't really refer to them as statin treatment groups anymore, but that is essentially where they came from. So there's 4 groups. We have the secondary prevention groups, the people with established cardiovascular disease. We have individuals who look like they have we have adults over the age of 20 who look like they have an inherited cholesterol syndrome or severely acquired causes of high LDL cholesterol. So their LDL cholesterol is greater than 190 milligrams per deciliter. The writing group in 2013 thought that was a metric that called out a separate entity of people who have an inherited risk for cardiovascular disease on the basis of their LDL cholesterol alone. And that group should be offered treatment with high intensity statin therapy as first line approach. We have our adult diabetics between the ages of 40 and 75 years old who don't have LDL cholesterols over 190. In fact, their LDL cholesterols can be between 70 and 189 milligrams per deciliter. They felt that which is basically the entire population of all diabetics between the ages of 40 and 75. They thought that the clinical trial evidence supported the use of statins in that population. And then there's pretty much everybody else should be considered for whether or not they should consider medicine to reduce their cardiovascular risk. And that is all adults between the ages of 40 and 75 years old who don't have heart disease, who don't have a high LDL cholesterol, and who don't have diabetes. And that's where we use our risk calculators and things like imaging to help assess how much plaque they have and how aggressively you'd want to treat them. And there are features that, there are some individuals who have personal features that aren't captured by risk calculators, like family history of early heart disease is not captured in risk calculators. Neither is having had preeclampsia during pregnancy. Neither is having chronic kidney disease and a whole host of other so-called risk-enhancing factors where if you have one of those features, it doesn't necessarily mean you qualify for pharmacologic therapy with statins or other LDL lowering. But it does suggest that we're underrepresenting your risk. And that if you fall into an intermediate category of risk, they thought that the evidence was strong enough to actually recommend the use of coronary artery calcium scoring in adults in that age group to look for signs of enough atherosclerosis to justify pharmacologic treatment. But that's where the evidence lay in 2018. We now have expanded age categories and expanded risk calculators that start as early as age 30. That's a big improvement. I mean, that's a whole decade more of individuals who we may have been leaving behind. We recognize that imaging is a really important part of decision making. And we know that imaging can be used. There's lots of different modalities that you can consider as part of your decision making. There's different features of the different imaging studies, so you have to pick the right one for the right person.
This episode is proudly brought to you by 38 Terra. Thinking of getting a gift for your gut this Black Friday? May I suggest 38 Terra's DMN Prebiotic, the science-based daily multivitamin for your gut microbes. A simple and delicious way to take your gut health to the next level. Get 20% off your DMN this Black Friday at 38terra.com. That's 38terra.com. The 20% discount will be automatically applied at checkout, valid between November 25th and December 3rd. When would you use the CT angiogram in clinic versus a coronary artery calcium score?
Access to CT angiogram right now is a privileged thing. I would love to see a CT angiogram in anybody I have concerns about the amount of atherosclerosis they have.
What's a CT angiogram cost? Roughly?
Roughly over $1,000.
Wow.
Yeah. And it varies, I think, by institution.
And does insurance cover that if you meet a certain kind of risk profile?
No. It covers it if you're using it to assess for ischemic symptoms. So it's a a recommended tool to evaluate somebody who has symptomatic conditions. I don't know what all of the diagnostic codes are that will justify it to an insurance company, but it can be a tool to understand why somebody is having chest pain, for example. But in somebody who doesn't have any cardiorespiratory limitations and does not have established atherosclerotic cardiovascular disease and just wants to know, like, gee, I wonder how much atherosclerosis I have and whether or not it's plaque that looks unstable and fragile and has features that put me at short-term high risk, that's going to be an out-of-pocket expense in the United States, and I presume almost everywhere. And so there are patients who come in and say, oh, that's okay. Oh, it's only $1,000, no problem. I'll take one, and I'll take one for my spouse also. And you can learn how to manage their care based upon the information you get. It is probably the best non-invasive tool to know how much atherosclerosis and what the nature of their atherosclerosis is in their coronary vasculature. Absolutely.
Wow.
But it's not practical.
They run Black Friday, Cyber Monday sales.
That's a great idea. So every institution probably charges around the same ballpark, but it's a terrific tool. It's safe. It's well validated. It's the amount of intravenous contrast is really quite low. You have to give we usually at my institution, we give 2 doses of oral beta blockers just to slow the heart rate down enough so that you can enhance the image that they get. But that's a technical thing. And it's terrific information. There's software packages that enhance the information that is available so that not only can you look at flow limitation in the coronary arteries, which can impact decision-making, not just about short-term treatment, but also about long-term treatment. And then that software packages also enable information about plaque morphology. We're not quite sure how to use that yet, but I think those of us in the field we think that may turn out to be important, and we're going to learn more about that. And I should disclose that I'm on, I'm a consultant for a company and participating in a clinical trial where we're trying to assess that very thing. So there's a couple companies that have software packages that enhance CT angiogram for that purpose. We don't use that much CT angiogram because I don't have that many patients who, for this purpose, I don't have that many patients who come in and say, oh yeah, I'll pay that dollar amount for that information. But we use a ton of coronary artery calcium scoring and far less, but still some carotid intimal medial thickness testing. So those are 2 imaging modalities that we use. And the one I use the most is the coronary artery calcium score. So that's a CAT scan that's gated to your electrocardiogram so that you take the picture at the right time. It's a tool that estimates how much plaque you have by looking at how much crusty plaque you have. So it's a coronary artery calcium score. It's looking at the amount of calcified plaque in your coronary arteries. If you have significant atherosclerosis and plaque buildup, you're going to have some of that is going to be calcified. And the longer you have that plaque, meaning the older you are, the higher the percentage of plaque is calcified.
Is that an informative test to do for someone who's in like their 20s or 30s or 40s, or does it require more time to kind of see calcification?
It definitely has greater value the older the person. It can have value in a younger person, but it doesn't have much, if any, negative predictive value in a younger person. So the test itself can either have negative predictive value or positive predictive value.
Meaning that if you're 30 and you do it and you have no calcification, that doesn't mean you're low risk.
Exactly, because at age 30, while you can do it, and I don't have the numbers off the top of my head, but I believe less than 5% of the population is going to have calcified plaque at age 30. And if you have calcified plaque at age 30, that means that you are developing atherosclerosis at a highly accelerated rate and faster than 95% of the population.
Whereas if you see a 70-year-old and they have no plaque, that's a pretty good sign that they're low risk?
Yeah, that's fantastic negative predictive value in a 70-year-old. I think, it's commonly referred to as the power of zero. So the power of a 0 coronary artery calcium score in a person who's old enough where that is really important indicator of their short-term risk. If they're old enough, do you really care what their
what age do you think that is?
is?
Where it becomes very predictive that they're not going to develop atherosclerosis, and that's not going to kill them.
Well, those are different things, but I think, a calcium score of 0 at age 50 starts to have some comfort. At age 60, I'm starting to feel a lot more comfortable about their risk. By age 70, I'm thinking about giving them a high 5. And I've done calcium scoring up to about age 80. I think I have scanned a handful of people at around the age 80, but that's not common.
Is it not possible that you could be 70, have no calcification, but have a lot of soft plaque, or does that not really happen?
It is possible. My bigger concern is that you're just taking a picture of the wrong body part. So you can, and anyone who's over the age of 70 will tell you the same thing. Doc, I don't really care if I have a heart attack, but man, I am so scared of having a stroke. And so stroke is much more complicated than heart attack. When our patients have heart attacks, 95% of them have them because they have atherosclerosis in their coronary arteries. Stroke, atherosclerosis in the cerebrovasculature accounts for less than 1/3 of the strokes. Stroke occurs also due to high blood pressure, just hypertensive strokes. You can have embolic strokes due to clots that form in the heart and travel to the brain, or little plaque that breaks off from the aortic arch that travels there. Or you can have strokes that is due to intracranial atherosclerosis. So we published a case report of a patient of mine who had some other unusual metabolic features, but after she had her stroke, and we really defined her intracranial atherosclerosis well with CT angiogram of the brain, we demonstrated that she had no observable atherosclerosis in her coronary vasculature or in anywhere else. Her calcium score was 0. She had a lot of intracranial atherosclerosis. So I do sometimes get concerned about undertreating someone or telling them, hey, your calcium score is 0, you're 70 years old, I think you're fine, if they have other features that would suggest they're not fine. So if they have high blood pressure, or they're smoking, or they have some other thing, they're not fine. You need to pay attention to their risk for atherosclerosis and other causes of cardiovascular diseases.
Is a carotid ultrasound, that's what you use, right?
Yeah.
Is that pretty effective at picking up plaque in those arteries and determining your risk of stroke?
Yeah. So there's different ways that you can do carotid ultrasound testing. The most common way to do it is not helpful for looking for atherosclerosis. So you can do Doppler technique, which tells me about the flow in the artery. The carotid arteries, though, are big, wide diameter arteries, and you have to have a lot of plaque to affect flow. So if somebody says to me, I want to know how much plaque I have, and I think to myself, I want to look in the carotid arteries, I can't just order a straight carotid Doppler study that's going to measure flow. That's not going to be the information of interest. So there's another way to look at the carotid ultrasound. You can use what's called B-mode ultrasound, where you actually look at the wall, the arterial wall, which is where atherosclerosis develops, and you can get commentary about the presence or absence of plaque. And it's quantitative, that when you do measurements of the intima to the media, the normal plaque thickness is going to be typically 0.5 millimeter thick. And there's some age nomograms that tell me about how it changes. You're talking about like fatty streaks. Like you can see changes over time for sure. And if you, for example, have a thicker intima-medial zone than the average person, that may suggest that you're developing atherosclerosis faster. But if you have frank plaque, meaning that the thickness of your intima-media is 1.5 millimeters, done. You've answered the question. This person already has plaque, regardless of who they are. You should pay attention to that. You should treat that. That doesn't necessarily mean that their carotid artery is going to be obstructed, but it's a marker of atherosclerosis in an arterial bed that is easily accessible by ultrasound.
And that's cheaper than a CT angiogram.
It's cheaper than a CT angiogram. At our institution, we charge the same for the carotid intimal medial thickness as we do for a coronary calcium score, which is $125.
Yeah. That makes me think of a study, CardioPrev. Have you seen that?
Yeah.
It was a dietary intervention, secondary prevention trial. And we don't have to get too far into the weeds, but my memory of this study was the participants who adopted this Mediterranean diet that was rich in olive oil, they had significantly less progression as measured by a carotid IMT.
Carotid IMT is tricky business. I actually thought it was going to go away completely. It's very user dependent. You need a skilled operator. You need up-to-date software packages and the right tools. And IMT in and of itself is probably not recommended for the general population, but the presence of plaque is something different. So when I'm talking about IMT, I'm talking about the difference between like 0.5 to 1.5 millimeters. There you're talking about like having to do very fine instrument measurements. It takes a long time. And, it's just not a reliable measure of the process of atherosclerosis. It has scientific interest. It can be used in something like a large clinical trial where you're trying to use it as a surrogate marker. I think there's some evidence for its ability to give us information there. But I'm talking about the presence of plaque greater than 1.5 millimeter thickness, which you can eyeball. You can look at the B-mode ultrasound studies and say, oh, look, there's a chunk of plaque there. And so Valentin Fuster, who you may know that name, he's really a living legend in the field of cardiovascular disease, just was the lead author on a big paper looking at large population and the role of coronary calcium scoring and the presence of carotid or femoral artery plaque. And to me, sort of revived an interest that I have in looking at this as a modality for looking for signs of atherosclerosis. So I think looking for carotid plaque, which is different than looking at the carotid intimal medial thickness, but when I order that test, I order it as the carotid intimal medial thickness test. But the piece of information is there plaque or isn't there plaque?
If you can afford a CT angiogram, is a coronary artery calcium score and a carotid IMT, are they redundant or are they adding some extra information that could be useful?
When you get a coronary CT angiogram, you don't need a coronary calcium score added on, but it's kind of nice to have that because we have lots of clinical trial data that tells us what to do with a calcium score, and we don't have that for CT angiogram.
So they just do it at the same time?
Yeah.
Yeah.
But you can learn additional information with looking at the carotids. It's a different vascular bed. And there are exceptions of people who, these tools are meant to tell us about the process of atherosclerosis. Like, is there much athero going on and how fast is it going and how bulky is it and what's your plaque burden? So we know that people who, as a way to estimate risk, we know that if you have single vessel coronary artery disease, your risk for a bad event is not as bad as multi-vessel coronary artery disease. And if you have multi-vessel coronary artery disease, it's not as bad as multi-vessel coronary artery disease and multi-vascular disease or polyvascular disease. So somebody who has coronary artery disease, but who also has carotid disease and lower extremity atherosclerosis disease, they're at the highest risk. They have disease everywhere, a ton of plaque. So their plaque burden is very high. So I'm never opposed to having more information about plaque burden for helping my patients understand what they need to do to optimize their outcome. But it's a conversation that you have about what their resources are. None of these tests are covered by health insurance for if you just want to know what their plaque burden is. But they are all available to individuals who have the means to pay. Again, I just know Philadelphia. In the Philadelphia area, we're talking about $125 for the calcium score, the carotid IMT, or over $1,000 for the coronary CTA.
What's an ApoB test cost if not covered by insurance?
You mean what do they charge?
Yeah, what do they charge?
It's different than what they cost. I've seen.
What's the true cost and what do they charge?
The true cost is less than $25 for the test, no matter where it's done, and it's probably less than $10. I don't know the actual number because it's so far from what is oftentimes being charged that I've stopped even paying attention to what the actual cost is. But it's a high throughput, well validated, easy test to do that every laboratory has the ability to measure.
Non-experimental.
Validated. Thank you.
Let's underscore that.
Yeah. And so individuals should not be charged much for this. However, if they're getting that tested at an institution that has to send it out to some outside lab because they don't have the assay, now you've just added cost to the process unnecessarily. So, and that's a real thing.
Let's go through a couple of case studies, my own, and then maybe a hypothetical case study if we have time.
Will I have to bill you when we're done?
Yeah, of course.
All right.
Have you got that prescription pad handy?
We actually don't use those anymore, but I'll be able to help you out if you need to.
Okay, so you know a bit of my history, but if we get the listeners up to speed. So my dad had a heart attack at 41, 42. And prior to that, he didn't have, a diagnosis of cardiovascular disease. He wasn't taking lipid-lowering drugs or blood pressure-lowering drugs. Those. By the way, Simon,
I'm going to cut you off for a second.
Sure.
As soon as you say my dad had a heart attack at 41 years old,
we don't need to go any further.
We do, but I've already in my head started the process of thinking about, boy, we need to really protect this guy. To me, that's a red flag for high risk. So I'm glad we're talking about this, but I want you to know that I've already sort of in my head thought to myself, this is someone who would probably benefit from pharmacotherapy as well as a healthy lifestyle. Sorry to interrupt you.
No, of course. So that came out of the blue. He wasn't on any of these medications, and even after the heart attack, his cholesterol wasn't crazy high. Blood pressure wasn't crazy high. These were pretty much average for someone of his age living in Australia. We don't have high Lp(a). Both of us have had that tested. It's negligible, which is great. My LDL cholesterol, going back to tests that I could dig up, I believe was around 110 to 120 milligrams per deciliter for the better part of 30 years. And then when I was 30, I changed my lifestyle a fair bit. I started eating a diet that was much higher in fiber, unsaturated fats. So not a low total fat diet, just low saturated fat, lots of unsaturated fats. And was able to get my LDL cholesterol down to around 70. And my ApoB, it hovers around that. Sometimes it can be in the 60s, sometimes low 70s. So that's where I'm kind of sitting today, without high blood pressure, without poor metabolic health and signs of insulin resistance, anything like that. Triglycerides seem to be optimized. HDL is good. Am I someone who should be doing imaging to see what's going on in the heart and or carotid arteries? And would I be a candidate for lowering ApoB with medications? And how would we determine kind of how low we would want to go?
You're a tough case. I'm going to have an answer, but I will tell you that I'm sure you could, if you saw 10 different people who do what I do for a living, you'd probably get a wide variety of responses. Did you say what your LDL cholesterol pack year history is? Did you calculate it?
Well, I can do some numbers off the top of my head. I mean, it's well north of 3,000. It's probably approaching 4,000.
I thought I was going to stump you there because I honestly, I don't know how how to calculate LDL pack years. That's what I was getting at. Earlier, you asked me about that.
Well, I just calculated, let's say I averaged 120 over 30 years, 120 by 30 is taking me over 3,000.
And then you factored in that since 30,
I had it lower.
Yeah.
They were rough numbers. Not a mathematician.
Exactly. But, so you're someone who actually has a lot of the data, so you can do things like that. And that probably has some value. And of course, this is going to be an LDL cholesterol based response, because I guess you only have ApoB in the more recent past, and we don't know what your ApoB level was before you made those changes. But it sounds like it's concordant now, and presumably it was concordant before. So you probably did not have a very high ApoB level, but you certainly have a high enough ApoB level and LDL cholesterol to generate atherosclerosis. So it's fantastic that you made the changes that you've made, and what you've achieved by lowering your LDL cholesterol that much is probably clinically significant. That it goes beyond just the LDL cholesterol lowering. So there are probably some direct health benefits to having made those changes that improve endothelial health and maybe improve blood pressure, and that go beyond just the LDL measurable factor that's there. But remember, you can develop atherosclerosis still with levels where you have, and it still can progress. And the amount of LDL cholesterol lowering that you've achieved is similar to what you would get with a moderate intensity statin. And a moderate intensity statin in a young person should offer good protection over the course of the rest of your life. So I think it's arguable that you've done enough, that if you just look at the evidence available from randomized placebo-controlled clinical trials, that you can say, bravo, keep up the good work, make sure you stay on this plan, don't make any changes, don't use any pharmacologic therapy to reduce your risk further, and that's adequate. On the other hand, you may also have significant atherosclerosis that you're incompletely treating, because we know there's residual ASCVD risk simply on the basis of your LDL cholesterol at this range. And we know that because we have multiple clinical trials in primary and secondary prevention that show us that when you lower LDL cholesterol that much, there are still people who go on to have cardiovascular events. So you can potentially enhance your outcome and reduce your chance of having cardiovascular events by trying to achieve LDL cholesterol levels that are more akin to wild animals. LDL cholesterol in that sort of 25 to 50 milligram per deciliter range, as opposed to in the 70s where you are now. Levels
ApoB in a similar ballpark.
Same ballpark, yeah. Levels that have been achieved in randomized placebo-controlled trials now with non-statins added to statins. So would you potentially benefit from pharmacologic therapy to get you down into that range? I would add one more thing about which pharmacologic agent. So I was trying to be generalist about this, but back in the 90s and the early aughts, the industry sort of recognized that statins seem to lower cardiovascular risk more than you would have expected based upon their LDL cholesterol. And there were biological properties that were identified with bench research. And as far as I can tell, they invented a word that I have never heard used with respect to anything else, which is the pleiotropic effects of statin drugs.
That's a great word.
It's fantastic. I have no idea what it means other than some magical property of the drug itself.
Right.
Do you know that if it means something else? Yeah.
Well, I think pleiotropic means it's having multiple effects, other effects.
Okay.
Yeah.
Yeah.
I think that's what pleiotropy means, but I mean, someone can fact check me. I think it means that it's not having an isolated effect, it's having multiple effects, different mechanisms, something like that.
Yeah, that's how I understand it too. And so it is possible that just like you can have pleiotropic effects from the dietary changes that you made, I'm sure that you did more than just lower your LDL cholesterol by making those changes. I think it's possible you could have some pleiotropic effects from statin drugs. I don't hang my hat on that. I just bring it up as a notion that is, maybe I'm dating myself by even mentioning it, because I think one of the things that we learned ultimately with something called the cholesterol treatment trial is meta-analysis of all the statin trials. So if you've heard of the CTT analysis, came out of Europe, where the European group looked at all the big RCTs, and they showed that there's a roughly linear relationship between LDL cholesterol lowering achieved and relative risk reduction when you looked at all of the big landmark clinical trials with statin drugs. And there were 26 of them in this meta-analysis. That's a huge meta-analysis of clinical trials. And with such a strong linear relationship, which, by the way, has been done with non-statins now, and all of our non-statin therapies fall on the same line, the same regression line.
So no matter if you use a PCSK9 inhibitor or bempedoic acid or a statin, for every milligram per deciliter reduction in LDL cholesterol achieved, you get the same risk reduction.
Exactly.
Which tells you that these are all acting via the same mechanism.
It seems to be that the main mechanism is there's less LDL in circulation. So if there's a magical property to statins, I don't know what it is. I think the real magic is the abundance of clinical trial evidence compared to ezetimibe, compared to PCSK9 inhibitors, compared to bempedoic acid. 26 major clinical trials, landmark clinical trials, assessing whether statin versus placebo reduces risk, or high intensity versus moderate intensity statin reduces risk.
I think the more I've had conversations on this as well, I've been able to kind of reassure myself that a lot of the fear that can be generated online about lowering LDL cholesterol, some of it is certainly warranted, but some of it seems to be unwarranted, in that you'll see people making claims that, Simon, don't take lipid-lowering drugs because you need that cholesterol to synthesize hormones, like you mentioned before, not understanding that all cells are producing all the cholesterol they need for that, and that knocking cholesterol down in the blood, at least to my understanding of the conversations I've had, even to very low levels, isn't going to affect the production of these sex hormones, for example, or isn't going to affect the cell membrane, where cholesterol has an important role, because those things are dependent upon cholesterol synthesis inside the cell, not pulling cholesterol out of circulation.
Yeah, reducing the LDL in the circulation, not reducing it in the cell.
I mean, that just seems to be a misunderstanding of physiology. I kind of understand how people can jump to that conclusion. Yeah. Right? Cholesterol is important for hormone production, therefore you shouldn't lower in the blood, not understanding that these are like separate compartments. And then the other one is brain cholesterol synthesis, which I recently had a very long discussion with Dr. Dayspring on. And that, again, was reassuring for me that brain cholesterol synthesis is separate to peripheral cholesterol synthesis, both in the liver and in peripheral cells, and that these lipoproteins aren't even, for the most part, crossing the blood-brain barrier. So that's been very reassuring. What would be the major side effects that could be seen from lowering my LDL cholesterol down even further from say 70 down to 30?
I don't think there's any side effects from lowering the amount of LDL in the circulation. But I do think that some of the medicines have specific potential side effects, and it's not related to lowering the LDL cholesterol. PCSK9 inhibition, highly confident, does not have any major risks to our physiology. It directly affects LDL receptor recycling. And I don't know yet whether it does anything else beside that. but it so far seems to be its main mechanism and the only one of import. And I can't find a reason to be concerned about that. Now, there is a difference in side effects in people on drug to inhibit PCSK9 compared to people who are on placebo in clinical trials. But the side effects are nuisance ones and minor and hardly worth repeating. And they're different between the monoclonal antibodies versus the siRNA therapy. So I start with the easy one. That's because I think PCSK9 inhibition seems to be the easiest one because it mostly just reduces the amount of LDL in the circulation and it's not affecting cholesterol synthesis.
So is that where you would start with someone like me if I was saying I'm down for getting my LDL cholesterol down?
Yeah. So no, because we live in a real world where these things cost money. And the current standard is to start with statin therapy because of the wealth of evidence and that taking statin drugs reduce cardiovascular outcomes in a wide range of patients, people who have established heart disease, people who don't have established heart disease, but they have major risk for heart disease because they're diabetic and hypertensive, and people who have high levels of LDL cholesterol or people who have more moderate levels of LDL cholesterol but have other features like an elevated HSCRP. So the wide range of patient types, a wide range of LDL cholesterol starting points, we learned in the early 2000s that in patients with established heart disease, it doesn't matter whether you have a high LDL cholesterol, a normal LDL cholesterol, or a low LDL cholesterol. If you have established heart disease, you will reduce risk by taking a statin drug. So we know that we can reduce risk. So what's the downside? Well, they're quite safe. I'm never concerned about causing an irreparable, irreversible problem by giving somebody a statin. But they're not that well tolerated, and they've got a terrible reputation. As all you have to do is turn on the interweb to find out what their reputation is, and you'll see people giving all their opinions about statins do this, statins do that, and some of the things that you mentioned are legitimate, but there's lots of magical thinking about what statins do. And the reputation of statins is powerful, and it's hard to fight against that, but they're quite safe. I have some concerns in people who perform exercise at a high level, especially if they're making their living that way. So athletic performance, which is sensitive to subtle changes in musculoskeletal function, I would be a little concerned about, maybe starting somebody as their principal therapy being statins. But if you do recreation and exercise for health and fitness and well-being, and you're not making your living at that, the side effects are nuisance and dose dependent. So we can find a dose that works well for our patients who are in that category. And that's the most common side effect, right? The musculoskeletal side effects. So that's, and by the way, I forgot to mention, they're guideline based and they're cheap as dirt. They're basically given away. There's the only companies that are making money off of statin prescriptions are the generic companies that manufacture them. I assume they make money off of them, but there's no branded statin therapy that we use. So
right, there'd be more money to be made by selling PCSK9 inhibitors to everyone.
Of course.
Well, where do ezetimibe and bempedoic acid land?
Well, I think ezetimibe is sort of your next option. Like let's say, for example, you were hoping to achieve a 50% LDL cholesterol reduction, or you wanted to target an LDL cholesterol level between 25 and 50 because of your family history of coronary artery disease. And so you get to a certain level by taking your statin, and you're like, boy, I don't think I can, exercise at the same level on the dose that Dr. Soffer recommended for me, so I'm going to take a lower dose. And on your maximally tolerated statin, you're not quite at the range. But you can eke out another 18% LDL cholesterol lowering by adding ezetimibe. And I've heard Tom on your podcast talk about how ezetimibe inhibits, sterol absorption that goes beyond just cholesterol, and talked about the potential downside of, phytosterols as a toxin. And, Tom was one of my teachers, and I feel persuaded by everything he says, of course. And so I give credence to that. But the clinical trial evidence for the benefits of ezetimibe is modest, but maybe significant. We didn't talk about the impact of low-level LDL cholesterol reduction over a long period of time that we think about in our highest risk patients that we need to achieve big LDL cholesterol reduction. The more plaque you have, you need to drive that down really low. But we know that from observational data, Mendelian randomization data, that if you inherit gene variants that lower your LDL cholesterol by a small amount, that when you're 50 years old, you have a reduction in risk for cardiovascular disease compared to your cohort that can really only be explained after multivariate analysis due to that LDL cholesterol lowering. So a small dose reduction in LDL cholesterol for a long period of time can go a long way to improving your cardiovascular outcome. And when you compare that kind of thing, Brian Ferentz and the group from the EAS did this. They looked at the same amount of LDL cholesterol lowering achieved with drugs in clinical trials. It dwarfs what you can achieve in those 3 to 5 year, maybe 7 year clinical trials. So long-term exposure to even modest LDL cholesterol lowering has an amplified effect over time. That's that cholesterol pack years that you can achieve from a genetically inherited variant.
So for someone like me, if I've come to the conclusion where, I'm going to take a low dose, low intensity lipid lowering drug to try and get me into 30 to 50 milligram per deciliter range, physiologic level, so to speak. Is there any benefit for me to go and do a CT angiogram, or is that just for academic purposes and interest sake? Or do I just start lipid lowering therapy knowing that I have such a high risk, family history risk, and not play around with it?
We're outside the box here, but I think you appreciate outside the box thinking. I'll start inside the box first, though. So the American Heart Association offers some recommendations that are really foundational care for atherosclerotic cardiovascular disease. And they refer to it as life's essential 8. It's got a catchy title and a cool infographic that really sort of simplifies things. But these are things that you already know. And when you're talking about the foundational care, the pharmacologic intervention for people with atherosclerosis is on there. But it's, the list is, eat a heart healthy diet, exercise regularly, maintain a healthy body weight, make sure you manage sleep and stress. Not sure how to do that exactly, but do that. Don't smoke cigarettes, keep your blood pressure excellent, lower your LDL, and optimize glycemic control. Other parts of foundational care for people at high risk also include, and now we're beyond life's essential 8, but also include antiplatelet therapy. So if you have a lot of atherosclerosis, we use antiplatelet therapy. We put people on aspirin therapy if they have established atherosclerotic cardiovascular disease. There's some imaging, there's evidence from imaging studies that suggest that if you have a high plaque burden, your risk for cardiovascular disease starts to look like those of people who with established heart disease, and what the justification may be for using antiplatelet therapy. So rather than classifying everybody who's never had an event as primary prevention, thinking about subclinical atherosclerosis on imaging as a tool to understand who in that category has high enough risk to warrant other things like antiplatelet therapy. The risks from aspirin therapy are higher than that from lipid-lowering therapy. Like, I don't have to talk about an irreversible...
Like bleeding risk?
Yeah, bleeding risk. And
hemorrhage, stroke.
It's usually, hemorrhage, cerebral bleeding is the worst case scenario, but gastrointestinal bleeding is probably more common. Young, healthy people have very low risk for bleeding from antiplatelet therapy. the older you get, the higher the risk. So it's a little different if a 75-year-old says to me, hey, should I do an imaging study to see how much plaque I have so it can inform me about whether to use aspirin? Now you're into some, tough territory, because even if I find that person has plaque and I wish I hadn't looked, now I'm faced with this tough decision of should I use aspirin therapy in that population? And that's where the risk of bleeding from aspirin starts to go up. But if I know they have a high plaque burden, I will recommend aspirin.
Yeah, I think my dad who's almost 70 now, has been on aspirin, statin of some type, and PCSK9 inhibitor. Yeah. The three of those.
So he has established heart disease and he's done great, right? He hasn't had any events since 41 years old. So, it sounds like he's doing well, and presumably he does not have significant progression of atherosclerosis. We have other therapies, though, that reduce risk for people with cardiovascular disease. We have evidence now that taking semaglutide, if you are overweight or obese and have atherosclerosis, reduces your cardiovascular event rates. We have evidence, there's conversations about how strong this evidence is, but icosapent goes by the trade name Vascepa, reduces cardiovascular event rates in people with established cardiovascular disease and high triglycerides.
That's 4 grams of EPA.
Exactly, yeah. 2 grams twice a day with food. And then we also have evidence for the use of colchicine. At low-dose colchicine, which is an anti-inflammatory therapy, reduces cardiovascular event rates in people, regardless of whether we know that about their inflammatory status, although it probably should be reserved for people with evidence, some sort of serologic evidence of inflammation. It's a complicated drug and its uptake has been slow, but this is sort of the latest in our armamentarium. I'm not suggesting that a high calcium score would necessitate these non-foundational therapies, but I think it's something to think about in our patients if you're really trying to optimize care, that we sort of think about all the ways that we can adjust care. Most of those last 3 things, the semaglutide, the icosapent and the colchicine, are primarily for people with established disease.
Okay, so we'll move on from my case study to another one that might be relatable to a certain section of the audience. But just quickly, so from what I heard there, I could consider a statin, PCSK9 inhibitor if I could afford it. Sounds like maybe slightly better tolerated, but more expensive. And then aspirin for someone in my context, or not really?
You're asking really hard questions.
Hey, you said you're sending me the invoice.
I know. In general, so that's where I would want to see imaging before I recommended aspirin for you. I do have young patients who come in and say, my mom or dad died at 32 from a heart attack. And before they've said anything else, I already, in my head, they're on a statin and an aspirin. Because now, if, for example, there's some genetic factor that predisposes you not just to atherosclerosis, but atherosclerosis that's prone to destabilizing, I don't know, that's a pretty profound history. It's complicated. It's hard to rely just on history. But I tell you, when you're in you have to ask yourself what you're going to do when you're wrong, because you're always going to be wrong, right? I mean, hopefully you're right more than you're wrong, but there's always going to be times where you made the wrong decision. So you have 2 decisions here, drug or no drug. In the case of statin, decide whether to use a drug. If you give the drug and that person is doing great and they didn't need it, worst case scenario is maybe they're having side effects and you're wasting time having conversations with someone who probably doesn't need to be on the drug in the first place and whatever. It's just time. But there's no irreversible bad consequence to having taken it. But if you opt not to take the drug and you're wrong and they have enough atherosclerosis to have an event and their event is a catastrophe, you miss the opportunity to take advantage of that drug. The same scenario is with the aspirin. So you have to think about that scenario when you're wrong, not when you're right, but when you're wrong.
How reliable is measuring CT angiogram kind of over time and determining progression. So like if I was to go and do one today and I said, look, I'm not going to do a statin, but I'll do another CT angiogram in 5-10 years and you let me know if I've progressed.
I don't want to say the wrong thing. I'm definitely not an expert in that, but I think that's a science that we don't have a lot of data yet. I can tell you people in my field have a lot of bias about what to do with that information, but I think that's something that really is ripe for more study. And I can give you some names of people if you wanted to really do a whole conversation about imaging, people with far more expertise in this than I have. Yeah.
Okay, let's slide over to one more case study before I let you go, fly back to Philadelphia on the red eye. So let's pretend that you have a kind of mid-60s woman presenting to you. She's gone through menopause. Her LDL cholesterol has bumped up significantly. She noticed this increase. It's at 120 milligrams per deciliter. Her physician has recommended that she's come to see you. She does have a coronary artery calcium score. It was 0. She hasn't measured ApoB. She has no history of events, but she's wondering if she needs to be concerned about this elevated LDL cholesterol that has been a kind of more recent thing that she's noticed.
Well, on the surface, she seems to be at relatively low short-term risk and probably not at much long-term risk for cardiovascular disease either. I want to make sure that her blood pressure is good, that she's not a smoker, that she doesn't have any other health problems, that like secondary factors that may be masking risk in her, the so-called risk-enhancing factors like history of inflammatory diseases, history of pregnancy-related complications. I think the list goes on. But I do want to know some other features of her metabolic status. I want to make sure that there's no signs of insulin resistance in her. And I want to measure her ApoB and her lipoprotein (a). But if she says, "Doc, please don't do anything that's going to cost me any more money than I need to spend," I think I'll have a pretty high degree of certainty that she appears to be at low short-term risk. Because even if she has a high ApoB or high Lp(a), disproportionate to what you'd expect based upon what we've heard so far, her calcium score is still 0, and her short-term risk is going to be low at age 65. So even if I find that she has some other feature that suggests that we're underestimating her risk, I don't think we're going to be underestimating it by much. And the National Lipid Association evaluated the potency of risk markers. I'm trying to think. I think it was around 2011. I know it seems like a long time ago, but the reason we haven't done it again since then is because there hasn't been any data that suggested something different at play. When you look at all of these risk markers together, the one that changes the risk strata significantly is coronary artery calcium score. ApoB, LPA, HSCRP, carotid IMT, they didn't really push the needle that much in terms of estimating risk. And the thing that's going to be most influential in estimating this person's risk with these features is at age 65, a coronary artery calcium score of 0 is favorable. I'd have to look up on the CACS MESA database how many women the same age have a calcium score of 0, but I would guess it's upwards of 65, 75% without looking at that table.
What if we kind of modify this case study a little bit now? She doesn't have a coronary artery calcium score, and you order one and it comes back with showing that she has calcification. At what amount of calcification would then kind of warrant a conversation around lowering that LDL cholesterol?
That's easy. So at 65 years old and no other risk factors for coronary artery disease, and she has calcified plaque in her coronary arteries, she should be on pharmacologic therapy to lower her LDL cholesterol. And I would probably tell her, depending on the amount of plaque that was recognized by that test, that an LDL cholesterol, once we've achieved an LDL cholesterol less than 70 milligrams per deciliter, we probably don't need to keep adding more therapy. But that would be a range that we'd like to see for somebody who has calcified plaque at that age. If the calcium score was greater than 100, remember I was mentioning about the aspirin therapy, at least one analysis suggested that that's a reasonable threshold for determining aspirin therapy in somebody at low risk for bleeding from aspirin. So a healthy 65-year-old woman, I'd feel pretty confident you could safely give her aspirin if she has a calcium score that's greater than 100. If her calcium score is greater than 300, which is a very high score, now we're talking about a risk that's more equivalent to what we see in people with established heart disease, especially if the calcium score is greater than 1,000. Now she has a very high plaque burden and the same kind of plaque burden that we see in people who were in the Fourier trial, where they have established cardiovascular disease, it's stable, and who are already on high intensity statin. They benefited from additional therapy with PCSK9 inhibitor on top of the high intensity statin. So I would treat her the same way and that's how I would use the calcium score to stratify her risk.
And going back to the earlier part of the conversation, you would order ApoB to see if they were concordant?
Yeah, I'd be curious to know in her case, but either way, I've already decided to treat her. So I can't imagine in that scenario that an ApoB is going to dissuade me from wanting to treat her with therapy.
Let's finish off with the table in your consensus paper that went over the treatment thresholds. I thought that was interesting. So you had, I'll let you kind of explain, I guess, what the purpose of that table was. When I read it, I thought this could be particularly helpful for the clinician that might be listening.
Well, remember we were talking about how we formulated these levels of ApoB that were considered to be equivalent to LDL cholesterol based upon the clinical trial data that we had. We had the NHANES study for our untreated individuals who are over age 18. And then we looked at data from the Improve It trial and the Fourier trial in people who were treated. We felt that the untreated population really didn't need specific call out for ApoB equivalency, that you can estimate risk and base your decisions using the common standards that are available. But we formulated these levels in people who were expected to be treated because there are existing thresholds for LDL cholesterol to intensify treatment. So right now we categorize risk in people based upon the presence of cardiovascular disease and other features that accelerate cardiovascular disease. And there's three categories that we thought were important. There's people who are categorized as having very high risk. And by the way, these were not our designations. These were already existing from guidelines and the more recent ACC expert consensus decision pathway on non-statin therapy. But these three categories of people with established ASCVD at very high risk, people with established ASCVD at high risk, or also known as not very high risk, and then people with more intermediate risk. And so those are people usually who don't have established ASCVD. So based upon guidelines, we have 3 LDL cholesterol thresholds that tell us that if your level's above that, we should do more. And those thresholds for the 3 groups corresponds to 55 milligrams per deciliter, 70 milligrams per deciliter, and 100 milligrams per deciliter for LDL. When we looked at the data and compared ApoB, we came up with numbers that were actually pretty similar, but not identical. And based upon our assessment of the data, we thought that we should use numbers that were the following: 60, 70, and 90 milligrams per deciliter for ApoB. So if someone is considered very high risk, and their ApoB is over 60 milligrams per deciliter, that would be an indication to commence treatment, to get them under 60. To intensify treatment.
Yeah. Sorry, because they're very high risk. So
they're already on
it. If they were high risk, then it would be an ApoB of 70 milligrams per deciliter to intensify treatment again. And then if they were borderline or intermediate risk, 90 milligrams per deciliter.
Yeah.
Those are the levels at which you would say, okay, we should dial up lipid-lowering therapy for this patient.
Yeah.
Okay.
And, we talked about the Anne-Marie Navarre paper that came out around the same time, and they looked at similar data, and they may have taken a more practical approach to this, which is they saw that the ApoB and LDL cholesterol numbers in terms of milligrams per deciliter were so similar that they felt comfortable using the exact same numbers, that it was too much for clinicians and patients to have two sets of numbers in mind. And I applaud them for taking a very practical approach to that, because you can see our numbers are not that different. 55 versus 60, 70 versus 70, identical, or 90 versus 100. So I think it's not unreasonable to, if the next iteration of the guidelines thinks about this, to consider, using the same number. I think that might be a more practical approach. But, fidelity to the data, we chose to use these numbers.
I think that's a good place for us to land this plane, so you can go and get on a plane. Was there anything that we didn't get to that you wanted to kind of add here at the end or build on?
No, I think I told you literally everything I know, and I don't think there's anything I left out.
Good. That makes me feel good. Cool. Well, thank you so much. It's been super informative. Appreciate the work that you do, and I'm sure all the listeners will be super appreciative of everything that you've just shared with us, and also everything that you've shared along with your colleagues in this consensus paper. I'll put a link to that into the show notes so people can look at the images. There's some great images. Who remind me again who drew the?
Alex Sakers, Alex, cardiology fellow at
some fantastic images to help you better understand what discordance is and how that can look. And again, that table that we just mentioned there that goes over treatment thresholds for people with varying risk profiles also can be accessed in the paper, and super, super helpful. So thank you so much for taking the time to be with us today.
Thank you, Simon. Greatly appreciate this opportunity.
You're welcome. There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.